pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, for liberty and justice for all. If I could ask everybody just to stand for a moment, just for a moment of silence for Dr. Tricia O'Neill, who was vice chair of STAC, who died in a tragic car accident with her husband in February. Okay, thank you. If we all be seated. Val, if we can have a roll call.
Okay, good morning, everyone. Dr. Bart? Dr. Berkowitz? Dr. Berry? Dr. Bombard? Dr. Cooper? Dr. Cushman? Dr. Daly?
Daly here.
Dr. Doynow?
Here.
Dr. Gomez? Dr. Isaacs?
Isaac's here.
Dr. Kugler?
Present.
Dr. Lynch? Dr. Markowitz? Dr. Maynard? Dr. Marshall? Present. Dr. Murphy?
Here.
Dr. Olson?
Olson here.
Dr. Talbot? Dr. Walters?
Walter's here.
Dr. Wislinski? And Dr. Winslow.
Winslow here.
Non-voting members: Orrin Barzilay, Aidan O'Connor, Mark Philippi. I know he is here. Marianne Potoro, Dr. Raybridge,
Here.
Michael McAvoy,
Here.
Steve Kroll,
Kroll present.
and John Washkow. We have 13 vetted members here. We have reached a quorum.
Okay, thank you, Val. I may be preaching to the choir here, but we have 23 members on SEMAC, and we have 13 people who have showed up. I'll just remind folks, and they probably aren't listening, but if you miss 3 meetings, it's time for you to move on, and you will be replaced by someone else. We need to have docs here. That's why you're on the list. So let's hope that next meeting we have a little better attendance. All right, let's move along here. Approval of the minutes. And I have a motion to approve the last meeting minutes. Okay, guys, does everybody need coffee? Thank you. Do we have a second?
Second.
Thank you. All in favor, please raise your hands. Anybody against? Any abstentions? All right, minutes have been approved. All right, moving along. Ryan, on to you.
Thank you very much. Good morning, everyone. Still morning, I think. Yep, for another couple of minutes. So good morning on the Bureau report. So at the top of the Bureau report absolutely would be the excitement of Part S and the legislative changes that went through in the governor's budget and all the feedback and everything that people provided. Really appreciate everything, and we're excited to see some really things that we hope will help in EMS sustainability and response across the state. So with Part S, for those of you who are not aware of what made it through and what did not, the parts that did make it through, and you can find this online if you look for it, as well as we'll make sure to share a copy with all the members of just this section of Part S, because it's a very long document that's not pertaining to EMS. But It talks about the expansion of SEMSCO and roles and responsibilities and the ability to do more things. I know over the years there's been some questions with SEMSCO and things of what can it do? Is it only emergencies? What about disaster preparedness and these things? And so it expands their roles and responsibilities. As well as in the REMSCOs, as things expand in the SEMSCOs, the possibility for REMSCOs to have additional things that they may be asked to do from the SEMSCO and to work with that one. A big one, which is new, and it showed up last year and this year again, is the System and Agency Performance Standards. And what this does is allows the SEMSCO to make recommendations on what should be put into a regulation on a system and agency performance standard. So what is a standard that's out there? What is something, a benchmark, that an agency should be required to live up to? On a pretty regular basis, I'm asked, well, you need to do something about that agency. They only get out 20% of the time. And unfortunately, we have to shrug our shoulders and say, well, today there's nothing that requires them to get out more than 20% of the time. We appreciate that they get out 20% of the time. The problem is that creates system instability, because when they only get out 20% of the time, the agencies around it don't know if it's getting out 20% of the, that time, or if they're not going to get out, and then how do they support? And so it really weakens the overall system. So over the past 2 days, we've heard on a pretty regular basis, and we brought up at each of the committee meetings about starting to think about what these system and agency performance standards will look like. And we're really excited to have this opportunity to now develop those and to look at the subject matter experts around this table and around this room and within the regional councils to say, hey, what do you think are the standards that we should follow? What is it out there that needs to happen in order to have sustainability? And to kind of work those forward. And hopefully the first step would be a small amount, right? We want it to be reasonable, we want it to be achievable. We want it to help strengthen a system, not weaken a system, not make it impossible for someone to do, but at the same time make it something that is going to grow a system and have people work towards a goal. And so at each of the committee meetings, we spoke about that. We spoke about it at systems. We spoke about it at the quality assurance. We spoke about it, at each of these, at education. And so over the next couple of months, we're going to start to see a working group, and there's been one person, particularly from systems, who's going to be leading the charge on that side to make recommendations, and then figure out priority. Well, what do we want to start with versus what do we want to end with? In the first go-around, probably want to end up with maybe 5, not a lot. And if you start looking at 5, maybe one's related to education, one's related to, response, one's related to, fill in the blank. But the other great part about the system and agency performance standards is it's developed today, but the standards of today may be different than the standards of 10, 20, 30 years from now, and those standards can continue to grow. We know where we are today. We don't know what medicine will look like in 20 years from now, and the standard today could be different. The standard today must be, your air ambulance that comes out of every EMS station, because now we're all driving in drones, could be different than what it is today. Probably costs the same amount of money, though. So we're really excited about that part. We think this will be a great one. I really urge all the physicians around the table to play an active role in this, to look at what they think would add to add to the system and agency performance standards, what should be included, what should be considered, to put them down on paper, and then we can decide which ones really are what they should be moving forward, and which ones maybe should move forward versus shouldn't. Remember, these will go into regulation, so there will be open comment period. It's not a short process. This isn't going to, oh, well, in September, we're going to institute 5 new standards. It won't happen that way. But hopefully by September, we'll have an idea of what we want to propose and where we want to go with that. The other parts are recruitment and retention, development of recruitment and retention on a kind of a twofold side. So half of that will be, not a half, but twofold, both being at a state level and a regional level, trying to have some regional components to it as well as a state component to it. A mental health and well-being program, the EMS task force. So the EMS task force, one of the things that we've learned over the past couple of years, through COVID and everything else, is that to be able to do things very quickly when the demand is there, and I don't mean quickly in the sense of necessarily minutes, but maybe hours, we need to be ready and have readiness in order to respond and meet those demands. So we're not talking about that, kind of where we're talking, that initial response. We're talking about a major incident, something else, a community that's larger. The most recent, not COVID, would be the Buffalo snowstorms. And we know in the Buffalo snowstorms that, there was an opportunity to bring more resources into an area after a certain part. But we also know that that wasn't the easiest thing to do, and what's the system, and how do we do it? How do we make sure not to pull from the most local of resources in order to not tax that system? And so that took us a number of days to get there. The EMS task force will hopefully have contracts in place with existing EMS agencies to be able to, on a dime, in a matter of hours opposed to days, have a response to a need in a community, and to help support them and stabilize them until, the task force can back out and say, okay, now you're back to, a normal frame set. So very excited on that one. Some other opportunities within the task force might be specialized equipment that a community would say, I can't financially afford to buy an MCI bus or something else that, a larger city like FDNY, says, oh, we have 3 because the system needs it there. Well, a region or an area may need it, but financially one agency can't. So task force possibly being able to buy resources or do things, and then possibly even to say, hey, we're going to put this into a region and have the region use it on a regular day-to-day basis. But again, disaster comes, that resource has to be ready to move and go to another part of the state. So also so that resources aren't just sitting and that they're actually being used and have value on a regular basis. And then the last big one within that Part S was health insurance eligibility for EMS ambulance agency members. This one I will tell you, I probably have the least amount of information on there, but we will be working on getting more information for the September meeting, just some more clarity on what that means. But it essentially gives the opportunity for active members to be a part of the health insurance program. And so when we talk about what are some of those recruitment and retention opportunities, these are things that add to recruitment and retention, that ability to offer more to our members, be volunteer, other options. In a few minutes, too, at the end of my report, OHIP is actually joining us today to talk about I believe it's a 34 or 36, forgive me, they'll correct it, $1 million investment in the Medicaid program for emergency work. So really just a tremendous year for EMS, a lot of recognition, from the governor's office and chamber, to support the functions, to help stabilize the system, and to, really progress us into the future, and to give us dynamics that allow us to adapt to changes as they move forward, and not just a fixed thing that's going to say, well, this will short-term put a Band-Aid on something. Some additional updates on regulations. So we have 2 packets of regulations that are in the process going up. We expect to see them out for public comment this summer. So please keep your eyes out for that. We will make sure to share it with all the SEMAC members and the SEMSCO members. Those regulations are for education and for operations. The operations are primarily geared around the equipment standards that the safety committee came up with. The education ones are around the education standards that were created by the education committee. Again, hopefully out for public comment this summer. One of the things I do want to flag for everybody around this table is there is an executive order that is currently in place that is EO4. EO4 is related to the staffing crisis, and there are a number of provisions within EO4 that are being used today, including the ability to take either the national exam or the state exam. If EO4 comes to an end, which is expected to come to an end around May 20th or 22nd, that would end some of those provisions, and we will make sure that everybody's aware that those have come to an end. Many of those provisions that we're using today, saying all the regs are passed and put into place that are proposed, that are in the pipeline, would be kind of reverted back into place. But there could be a window of whenever that EO ends until the new regs are in place for education, that some of those things won't be in place. So just keeping that one in mind. All right. For the rest of the Bureau update, investigations continues on investigations. Operations is out and seeing a lot of different agencies. We're getting back into places. Please remind your agencies to, they know we're coming. These are pre-scheduled, no surprises for the most part. Remind them to check their policies. Remind them to, have things accessible, to do their rig checks, to make sure that equipment isn't expired. We're on fairly regular basis running into situations so where it's not just equipment that's expired by a month, but it's a year or 2 years. So, just situational awareness on that one. Please, do your best to work on that. As medical directors, feel free to reach out to your district chiefs and, ask them, can you tell me a little bit about, what's going on in my region? They won't tell you specifics by your agencies. You should know your agencies. But they will tell you in general what's a repetitive, thing that we're seeing that, is a little bit different from region to region. On the administration side, we continue to finalize some of the contracts for the PAs and the REMSCOs. We also have a health system specialist position that's posted. That's going to be a new position, new district chief position within the Bureau. The Bureau is also excited to see a number of new positions coming down the pipe as the Department of Health continues to raise the number of, bring back up the number of staff members within the department. I think, it's a big initiative there to get to their base mark numbers. And so you'll see a number of positions around the state coming up for the Bureau of EMS. Please feel free to share them. On the education side, we're really excited about this one. So for the first time in many years, we have increased the funding for CFRs and EMT training at the base rate. It's a 15% increase for those two categories for the original classes. We expect to see a second increase. We are meeting with the Finance Committee on a regular basis. We have met with Steve Kroll and the work that he's doing and the survey that he's working on. So the goal is to determine where it is best to allocate some of that funding in those increases. Do we focus just on original classes? Do we focus on original and refresher classes? Whatever that might look like. So that is a big thing that's happening on the education front. We're really excited about that. In addition, we have 4 new educational pilot programs. The 4 new educational pilot programs, the first one is an EMT Academy program. This is now open to every single course sponsor out there. So every single course sponsor would be eligible to teach one Academy-style class at an increased funding rate for in a calendar year. The second program is an EMS internship program. This is designed for EMS agencies to be able to bring a person from the community and do some sort of an 8 to 12-hour engagement with them, teach them about EMS, teach them about the agency, whatever that might look like, and then they would be able to sign off on the training fund, essentially sending them to EMT school. So what we've heard in a lot of feedback is it takes 2 months, 3 months to get a person into a volunteer agency at times, and the EMT class started, 2 weeks before they would have gotten in. This would give them that opportunity to get in, and it would also give them an opportunity to sponsor some people who may or may not join, or maybe weren't thinking of joining the agency, but now all of a sudden will. So again, excited to see that internship. By the way, this is all out in policy statements. They're posted online already, so if anybody wants to either follow along or see it, they are up on our website. The second program is Intro to Paramedicine. This is a BLS CME pilot program where they'll get their BLS CME hours, but in addition, have an enhanced program to determine a little bit more about paramedicine, a little bit more about the math, the anatomy and physiology you'll have to know, the rigor of the coursework that's there, but give them that initial exposure. This is only being able, as a pilot, this is only eligible for paramedic course sponsors to run with, but it is an exciting program to be able to hopefully do an intro program and see where that leads, how many of those convert to going to become a paramedic. And then the last one is funding behind the EMS leadership training. This is a program that was developed for the state. It's a 2-day training. There is a 3rd-day option on recruitment and retention, but it's a 2-day leadership training and funding for that one. In addition, on the education front, we have some new PSI group scheduling that's happening. There's about a dozen agencies around the state that are trialing that out. If it goes well, we will advance that to more of our course sponsors. Essentially, what that means is that the instructor has the capability of scheduling everybody at one time. So they register online, then the instructor schedules them. This is to help in some situations where we're seeing them say, well, the students took 2 months to take their exam. So we're trying to reduce that and see what we can. There is also a new ADA process for readers. So following in the national standards as well, EMT or EMS providers who have an appropriate documented learning disability and meet the requirements of the Department of Health ADA Compliance Office could be eligible for a reader for their exam. This is a new thing for us. There was a lot of back and forth on it. There was a lot of discussion on it. This does not mean anybody who raises their hand and says, I want a reader, would qualify for a reader. It would have to be very clear in their documentation, through their testing, through their accommodations, that this is an appropriate accommodation for them, and then they would be eligible for that accommodation. The other big difference in that one is we are asking at this point for all of the students who need an ADA accommodation to submit their own accommodation paperwork through the portal on the EMS forms page. A copy of their submission will go to the instructor. So the instructor will know whether or not they submitted. But we are trying to get this stuff in a timely manner, and some of the paperwork is getting delayed in the process due to submission timelines. Data and Informatics met last week. They had a robust conversation on a committee or a number of days together to try and look at how do we reduce the number of required fields within the EPCR? How do we make it more collaborative for EMS provider to be able to complete their chart with less validation errors? And so we are working on that one. The goal that was given to Branch Chief Brody was reduce it by 25% if we can. I am told that we are getting closer, but we might not be there yet. But there's been a number of modifications and things. And again, hopefully that will work. I know that we also have ESO and Image Trend, who joined us here today, talked about some of the issues that are related to charts not getting through. There's obviously a continuation of care issue when charts don't get through, because if they don't get through, it's not only them not getting necessarily to an agency level, they're not getting to a regional level or the hospital, which is where we really want them to be, so when the care is being delivered, that it can be there. So we are working on all that as well. Next STAC meeting is tomorrow, May 11th. It's at the Albany Wolf Road Marriott. There are a number of changes to the 405 regs that are also in the pipeline for regulatory changes, as well as we will be honoring tonight, actually, Dr. Marks and Dr. O'Neill, who were the STAC chair and the STAC vice chair, who unfortunately both died within about a year of each other. So a big loss to the trauma community. The EMS for Children's grant was awarded on April 1st. Excited to see that being awarded to the state, and we'll continue on with a lot of great projects. The EMSC survey concluded on April 31st, and we're waiting to see some of those results. The EMS MSAC meeting was last week. Sorry. Nope, that one was off. We have updated the pediatric assessment triangle. That document is available online and printed copies here, Amy? And printed copies in the office, but we'd be happy to mail them out to region REMSCOs who would like some of those updated ones, as well as we also have badge buddies, so the badge IDs that go on. If any of the regional councils would like to have some of those, please reach out to Amy and we can send those off to the regional councils. Vital Signs will be October 17th to 22nd. Excited to have a really nice program this year. Looking forward to seeing everybody. Hoping to see those numbers continue to go up with the pandemic being over. We know that we went down in numbers during the pandemic, so hopefully that will continue to go up. In just a couple of weeks, we have our EMS Memorial on Tuesday, May 23rd at 11 a.m. at the Plaza. Everybody is welcome, and we encourage agencies to come. If you are going to bring a vehicle, please make sure to reach out to Val Oscar ahead of time so that we can get you, by the way, an ambulance or department-lettered vehicle. Please reach out to Val Oscar so we can get you parking space on the Plaza. It really is a very nice event. It is honoring 8 honorees this year, and so very excited about that one. We spoke about the executive order coming to an end possibly and what that would mean. The Rural Health Task Force. So the Rural Health Task Force met last week. Really great progress going on there, great work of the group, and really making some nice progress. Hopefully its September meeting will have additional updates for you. I know their goal is to complete their report by the end of the year or shortly after that, so that has more, looking forward to it. Just a reminder, the EMS Forms page is live on our website, and it really includes almost everything now, particularly all of our submissions, so please make sure to use that one. One of the new things that we're going to add to the EMS Forms page is a policy suggestion update. So if you see a policy statement on our website and you feel there's a better way of wording it, or something's outdated, or something contradicts it, we're going to be putting that up on our website, and going through all of our policies and working on updates over the next several months. And that is the end of my report. I am going to ask Rich Brandt, there he is, to step up and speak about OHIP, if he doesn't mind, and the supplement.
Good afternoon. I think most of you know me. For those of you who don't, I was involved in EMS for a couple of years. I now work for the Office of Health Insurance Program, and I'm pleased to bring you some really good, what I think is some really good news at this meeting. For those of you who don't already know, we were able to secure an increase in payments to emergency ambulance claims, which will begin on July 1st of this year. So it'll be 3/4 of the current fiscal year, the current state fiscal year, and then it will be permanent for all quarters of the following fiscal year, 25. What we did is we took Medicare for, if I'm over-explaining something, please let me know and I'll stop. But Medicare uses what they call an RVU system, a relative value unit system. Every January 1st, Medicare establishes a base rate for BLS non-emergency, which is considered to be the least expensive type of ambulance trip to provide, puts a dollar value on it, and then multiplies that times the RVU index, which is a number greater than 1.00. So I've got some numbers here to give you some idea. And this, again, these payment increases apply only to emergency ambulance claims, not to non-emergency claims. And so we're starting with a base rate of $195, which I realize is less than what Medicare pays for a BLS non-emergency trip. But for a BLS emergency trip, we'll be multiplying that by 1.28. For advanced life support level 1, we'll be multiplying that number by 1.52. For ALS 2 by 2.2, and for SCT by 2.6. It comes out to be a $38.4 million annual investment in year 2 of the budget. Again, because we're going to be a quarter late in implementing this. We still have some pencil sharpening to do in-house on our end. I think it's a wonderful thing. There are a few counties that have been fortunate, I guess, everything being relative, that already received more than this. Those counties will not be affected. They will not have their payments reduced. So this is good news that the total investment, it's with the state, it's 50-50. We pay half the Medicaid tab rather, and the feds pay the rest, the other half. So the state's investment is $18.2 million. The total investment is $38.4 million. And I think it'll make a significant difference. Those of you who've been around a long time remember I worked on a similar package with then Deputy Medicaid Director Liz Misa probably about 7 years ago, maybe. Al, you here? That sound about right? Okay. And we were able to get $31 million for the industry over a 5-year span back then. So this is a larger investment, and it's going to be put in place immediately starting 7/1. And again, it affects emergency claims. Any questions I can answer?
Yeah, good morning. First off, congratulations. Thank you. Every dollar we can get. Do we have to go down a different road with that?
I don't know. Probably we will have to travel. You're talking about the inpatient rate stay, DRG stay, basically.
Correct.
Yeah. I don't know. We did not address that with this.
Okay. So that's, just so everyone's aware, downstate, there's arrangements that have been made between the larger health systems in the state where ambulance services are not billed to Medicaid, but they're paid out of, I guess, the DRG that's paid to the hospital for the inpatient stay. And that's regardless of where we transport. So if we transport someone to not one of our hospitals, we still can't bill for that. We bill our own hospital for a transport to not our hospital, and that's everyone has to do that. So I don't know if everyone was aware of that or not, but that's kind of how the model works.
Right.
It's definitely something we need to look at from the hospital side to try to see if there's a way to get the rates increased for the EMS as well.
We are, and I don't want to wander too far off into the weeds here and take your time, but we are also working on another project. Actually, we could have had several children in the time we've been working on it, almost 3 years now. Certified public expenditures, which you're familiar with. I see you shaking your head. If you're from New York City, you're familiar with it. If we are able to get that state plan amendment approved by CMS, and it's been a arduous, torturous journey, that would do away with what you're referring to and put you on fee-for-service for everything. But that journey is far from complete, unfortunately. And if you think dealing with the state is fun, deal with the feds. So I'll leave it at that.
A question that came up at Systems yesterday was, is there any change in the definition of an emergency?
No, no, there is not. And the easiest way to look at this probably is that if it's a non-emergency Medicaid trip, you need prior authorization or you don't get paid. You do not need prior authorization for an emergency trip. So if you're moving a patient from a community hospital to a tertiary care center because the community hospital is unable to provide them with the care that they need, that is an emergency trip. And we will be keying these off here, HCPC codes, or as we call them, because we have to rename everything something different, we call them procedure codes in Medicaid, but they're the HCPC codes. So if you bill one of the emergency HCPC codes, it will be treated as an emergency claim. That RVU modifier will be applied to the rate.
Okay, thank you, Rick. Any other questions for,
A question, Dr. Dueno?
go ahead.
Thank you, sir, for being here. We've worked with Rich for a long time, and he's such an asset to us in this new position. Now, do these rates continue, or do they mature at some point?
No, they continue at this
Okay.
point, and the modifiers continue.
Okay.
The way it works with Medicare, as you know, is every January 1st, they raise that BLS rate, the 1.00 modifier. I don't know what we will be doing. I was thrilled to get $38.4 million and walk away with that. So I can't tell you what the future will hold.
I can't tell you how much our industry appreciates what you're doing, and that money is certainly useful to all of us. Thank you.
Your work matters, and you all know that. Thank you.
Okay, just want to remind everyone, when you're speaking, please state your name for the stenographer. Moving along, med standards if we can. What's that?
One last thing, if
Sure.
you don't mind. Nope, good, sorry. I just wanted to take a brief moment to, this is so sad. In August, so in just a couple months, but before our next meeting, District Chief Farrell will be retiring from us, who has been with us for the past 25 years and then has been a certified provider for the past 49 years. And we just wanted to say congratulations, thank you for all your service, and just thank you. So.
Anything to say, Joe? Okay, moving to med standards, Dr. Marshall.
Good morning, everybody. Good afternoon, sorry. Med standards met this morning, and we have several action items to bring forward. We do have some protocol changes that were submitted by the collaborative, and there are 3 of them, and I would like to bring them all to you and have one roll call vote, if that's okay with you, Chair? Okay. So, so the first protocol change is the Advanced Directive DNR MOST protocol, and the changes there improved, simplified the language within the protocol itself and makes it easier to read for providers.
We're trying to get them up there. They're not quite there.
Okay. Sorry.
Technical difficulties?
Okay, so this was the first one, and this is the Advanced Directives DNR MOST motion to approve the changes submitted by the collaborative for this. And there was, it was a unanimous vote with no discussion. The second one is the adult and pediatric seizure protocols. And the changes there are on the adult seizure protocol under paramedic. They added 10 milligrams of midazolam IM or IN, and it remained 5 milligrams IV and repeat in 5 minutes. Under key points, they added a bullet point to administer midazolam first, followed by magnesium if given, and additional midazolam may be given per protocol if seizures continue. On the pediatric seizure protocol, under CC, the dose of midazolam was changed from 0.1 milligrams per kilogram to 0.2 milligrams per kilogram IM or IN, with a maximum dose of 10 milligrams, which prior was 5 milligrams. Under paramedic, if the patient continues to seize, additional doses of midazolam can be given. And those are the changes to the seizure protocol. The third one that comes forward is pediatric and adult pain management. And under the adult pain management protocol, under advanced provider acetaminophen up to 1,000 milligrams, and they removed other dose options, so you can give what's appropriate. The same thing for ibuprofen, up to 400 milligrams. Under paramedic, ketorolac is now available, 15 milligrams IV or IM, as well as acetaminophen, 1,000 milligrams IV over 15 minutes. Also, other options include a new option, ketamine, 25 milligrams IV over 5 minutes or 50 milligrams IM. And it says can be consider weight-based dosing, not to exceed the previous doses I mentioned. Under key points, there are some clarifications and new section on nitrous oxide contraindications as well. On the pediatrics, changes included acetaminophen 15 milligrams per kilogram with the concentration added. The same thing for ibuprofen, 100 milligrams per 5 ml concentration. Under the CC, options including morphine or fentanyl. Under paramedic, maximum dose went from 5 milligrams to 10 milligrams for morphine. And then they added a whole new section on key points and considerations with multiple bullet points regarding side effects, contraindications of the different medications. And they added weight table with weight in pounds to weight in kilograms. So those three came forward, voted unanimously at Med Standards and comes forward as seconded motion.
Thank you, Dr. Marshall. Val, can we have a roll call vote on those?
Is
Dr.
there,
Doino?
Before you do the roll call vote, is there anything you want to talk about dates of when that would be posted or go into effect, just so it's clear and on the record?
So as we further discussed this morning, we have the New York State Protocol Development process. So at this meeting, these will come forward. They will be approved for implementation January 2024 with final implementation by June 2024 for all agencies. And this goes along with our process to have one annual rollout of new protocols, barring any exigencies.
Any questions?
Dr. Doino? Dr. Doino?
Yes.
Mark Philippi. Hello, sorry. Over here in my unusual seat. I had meant to mention this during Med Standards, and I apologize, I didn't get up fast enough for this, but in the adult and pain management, the changes there may be just a minor glitch, and I just want to understand what the SEMAC's intention is with this. There is a section that refers to the patient if they're able to tolerate oral fluid, considering giving one of the others. And then down below, it does appear to allow for the use of tablet form PO. So I just want to clarify, is it the intention that both PO and fluid versions of NSAIDs be available, or is it sticking with just liquid form?
I would ask Dr. Daly to comment on that.
The intention with doing it with the liquid form only was that way you didn't have to carry something separate in order to wash down the tablets. However, if somebody was to plan on doing that one way or the other, from an operational perspective, I can't think of any reason for us to micromanage that.
Thank you.
Any other questions before the vote? Okay, Val, if we can have a roll call vote?
Dr. Berkowitz,
Yes.
Dr. Cushman,
Gershman, yes.
Dr. Daly,
Daly, yes.
Dr. Doino, Dr. Gomez,
Gomez, yes.
Dr. Isaacs,
Isaacs, yes.
Dr. Kugler,
Kugler, yes.
Dr. Marshall,
Dr. Marshall, yes.
Dr. Murphy,
Murphy, yes.
Dr. Olson,
Olson, yes.
Dr. Talbot,
Talbot, yes.
Dr. Walters,
Walters, yes.
and Dr. Winslow.
Winslow, yes.
Motion passes.
Thank you. Dr. Marshall?
So the next motion to come forward has to do with development of blood administration regulations using a framework developed by the department and stakeholders. And we actually have a template, and we as a body are requested to come up with the regulations, if I'm correct, for the blood administration.
So as a body, it's a request to promulgate regulations, so to work through that. I'm happy to have actually Don Trepez step up and just talk a little bit about what's happened so far and what the next steps would be. Again, I just want to remind everybody here, so this is a little bit, we're moving into now doing a lot of regulatory updates too, both of things that are new. Last year, the blood legislation came in for air medical, but going forward, with Part S and everything else, there's a number of regulatory things that will come to fruition, and so we are working on that process. We're hoping actually by September to have something on paper too for everybody to see. This is one of the first because it came out last year, so we're just getting to this now once we figured out that process. And basically what we've done, similar to education, is to come up with a framework, and then we would take it to the next steps, but we wanted to make sure we were on the right direction and to have this group kind of move forward on that. Chief Trepez? Make sure to state your name.
Thank you. Don Trepez from the Bureau of EMS. So good afternoon. As the director stated, 3003 Bravo was passed last year. It was added to the public health law, provided the capability for air ambulance stocking and use and initiation of blood products in a pre-hospital setting. In the last paragraph of that section of law, it charges this body here to move forward with promulgation of regulations and send them forward to the commissioner for approval. At the charge of the director, we put together a committee of stakeholders, many of which are in this room, representing all of the air ambulance transport entities across the state who are already operating with blood products in the pre-hospital environment based on the law change, as well as stakeholders from the ground ambulance side of the environment as well. As we all know, there's a desire for that to potentially be included in future adjustments and such. Through that process, we developed a framework that you have there. We're glad to have Dr. Daly and a few other folks that provided some input and guidance as well. And the goal will be is if this body so moves forward with this motion, is to go back to that group of stakeholders and anyone else that is willing to be a part of that or wants to be a part of that. And we will formalize those regulations and hopefully have them presented for approval at this body in September. Again, that's to develop the regulatory portion of how to operationalize the blood products. There is no concern that there is not operationalized properly now, but certainly as part of the law, it creates that opportunity or necessity for the regulations in that circumstance. And just a point of clarity, there is a separation between the pre-hospital blood administration initiation that portion of the law covers and the ambulance transfusion service world. Those are two different environments and operate in two different lanes in that circumstance. That was a question that was asked previously.
No, if I can just speak to being a member of that group, that was a multidisciplinary stakeholder group, and it was one of the most impressive groups that I've had a chance to work with in a collaborative fashion. Don did a great job of herding the cats, and I look forward to that work product continuing to develop.
And just one additional shout out, thank you for the comment, Dr. Daly, and just one additional shout out to Gina from the Bureau. She's our policy fellow. She's the one that keeps it organized. I heard the cats and, as Dr. Daly said, but she keeps it all organized and puts it beautifully on paper. So thank you very much. It's a team effort.
For those of you who don't know as well, Chief Trepez, prior to being with the Bureau, was with an air medical and ground service as well, so has kind of a lot of knowledge on that front. Again, this is just for air medical. We know the desire is there for ground, and I think Al Lewis was talking about it before, but this is particular to air medical. Also, if you are wondering how are some agencies doing it today before the regs are promulgated, there was a period of time where, when it was enacted, where they could start the blood products and follow a certain set of standards, but it is still the directive to have further codified as regulatory, different additional regulations that go with it.
Any more discussion or questions on that motion? I don't know that we need just do a hands, yeah.
Okay, can we have a show of hands for members who were in favor of this motion? All in favor? Okay, anyone against? Any abstentions? The motion passes.
Thank you. And the fifth motion is for regional REMACs may require all EMS providers who provide EMS care in their region to complete a credentialing process to be determined by the REMAC. We had quite extensive discussion on terminology, the authority of REMACs and REMSCOs, whether it was credentialing, registration, or licensure. So this motion, after a lot of discussion, actually passed with one abstention or one no vote, and it comes forward to this body as a seconded motion.
Any discussion? All right, we have a show of hands of everyone in favor of this sorry, Dr. Berkowitz, go ahead.
Yeah, so I very much support this motion. I'm in favor of getting clarity on this issue, and I think that the only active issue regarding this specific, regarding credentialing between regions right now has been resolved. That being said, I have two concerns that I just wanted to raise. One is that, it seems that the Division of Legal Affairs have said that this motion is outside the scope of this body. So I'm not that comfortable with that aspect of it. And also, this will force a formal ruling on this matter, and I don't know what the downstream effect of that on our regions will be. So those are it's not questions, it's just kind of concerns that I have on it. But I am supportive. Thank you.
Okay, thank you. Any other discussion?
Dr. Doina? On the motion, the wording that is there would imply that EMTs, CFRs, EMRs, as well as paramedics would be subject to this credentialing process. Is that the intent?
Dr. Winslow, is your motion?
Yes, and also the stress should be on the word may require. I'm trying to make it as soft as I can, but just realize that this process is being done everywhere in the state and has been for 30 years. So we do need to have a comment on it, even if it pushes the envelope that it can or cannot be done. It does need to be clarified.
Any other discussion? Okay, if we can have a show of hands of all in favor of this motion? Okay, anybody against the motion? Any abstentions? One abstention. My motion passes.
Thank you very much, everybody. There was a lot of other discussion that happened. I just want to bring it to your attention. We had a very nice presentation by the Office of Health Emergency Preparedness regarding the KIMPAC planning and the KIMPAC program in the state of New York, and where the hub and spokes are around the state. And I think that one of the takeaways is that each region needs to be aware of the KIMPAC program within your region and actually drill and know who can activate it, because it could be any physician. And if I recall, many years ago there was an incident where a rural physician activated the KIMPAC because of an organophosphate overdose, and they needed all the atropine that they could find. So it does work. So please take that back to your regions and talk about it, and actually make sure you know who's supposed to have it and who can have access to it. We also talked about the medical device advisory that we approved at the last meeting, and which is fine, and we're not going to change that. There is a part of Article 3002A2C, which requires SEMAC to develop minimum standards for use of regulated medical devices, so which is separate or different from the medical device advisory that we approved, which was to ensure that agency medical directors were involved in the decision about which medical devices their agency would carry. So that would be a group that will get together and look at developing a list of maybe not devices, but categories that would be approved by SEMAC. We also talked about the medication substitution policy, which is 1304, and that we wanted to go back and take a look at it and revise it if necessary. One of the things that is not in there now is albuterol, because albuterol was not short back then, 10 years ago. So there may be other medications, so we'd like to we'll get some people voluntold to help work on this and update it. As well as, I believe the department is also in the process of going back and looking at a lot of the advisories and policies and making sure that they're updated and current, because a lot of them have been around since before many of us. So I think we also had a discussion about ISTAT and then use of ISTAT, which is currently being used in some specific instances, but maybe agencies might want to expand the use of that. I did look up and see that it looks like ISTAT is CLIA waiver, but I don't know which cartridge. So I would just advise any agency that's going to use that to just double check on that. We also had some discussion on wasting of controlled substances and who witnesses it when EMS arrives at a hospital and needs to waste controlled substances. And one region was having problems with one health system that did not want their nurses, doctors, or anyone else to witness the destruction of controlled substance waste by EMS. So I don't know if any other regions are having that issue, but just so you can be aware of it. And I think that's the end of my report.
Any questions for Dr. Marshall? So we need to have two committees put together, looking at what medical devices should be essentially FDA approved that we're going to have a list of. Would I have any volunteers at this point? Okay, if not, what I would, I'll be happy to work with you. Dr. Winslow, I'll be happy to work with you, Dr. Winslow, and Dr. Marshall. I just volunteered as well. And I'm sure Dr. Daly, I see his hand up, is happy to help.
You should talk to them about participating.
That was voluntold, I believe. There you go. Yes.
That'll be fine.
Happy
Also,
EMS week.
Med substitution. Does anybody have any specific interest in that? Substitution. Okay, come see me later and we'll set it up. Anybody else for med substitution? I hate to start appointing people because I know all you guys. Dr. Murphy, excellent. So now we at least have two people.
Mr. Chair,
I'll appoint them for you, don't worry.
Okay.
there's also a number of people who aren't here in attendance that might be qualified to help you and assist in this matter.
All right, we'll have those two committees going and hopefully have something to report back to on the next meeting. All right, moving on to education. Report. Okay. Don, report, please.
Thank you, Don Hudson. Good afternoon, everyone. So the education agenda is in the publicly posted minutes and agenda, so we'll just go through it quickly. We had an update on the BLS practical skills revisions that are proposed. That's just to refresh everyone's memory, moving to more of a scenario-based testing. And just to reiterate, that's going to be more of a long-term implementation. There's nothing coming down the pike soon. So we're looking at more months to years. So if you don't need to stress out about that, as it's still in the early phases, planning phases. Also, we had Chief Chesney from State Education present on the working pilot, I guess, of group scheduling and how that will be implemented as a pilot to see how that can be implemented statewide if it does work out. We have a joint project that we're working in conjunction with Steve Kroll's group in finance, looking at the core sponsor surveys, particularly the financial aspect of that, and commensurate with Director Greenberg's expansion of available funding for core sponsors to run EMS classes, to see what that looks like moving forward, what monies are also available versus what things actually cost, to continue down that road, and the acknowledgement that it's been a long time coming. We're thankful for the 15%, but we still need more. Alternative funding for EMS courses, we've come to be aware through our SUNY CUNY collegiate-based programs that there's probably other funding streams outside of traditional EMS/health scholarships and whatnot, grants that might be available to us, so we're waiting on some feedback and ideas from them on that. We also have a joint project going on with our paramedic course sponsorship partnership, reviewing the current state requirements for EMS instructor, both CLI and CIC, what that looks like with the national level classes available, and how that should be altered, if at all, in New York State. We did have a discussion about hazmat training. So in the National EMS Education Standards, there is hazmat awareness training required for all EMS providers. There's a number of different classes out there. The question asked was which ones meet the requirement, which ones don't. So we have that on the agenda for answers on the next meeting so that we can send out some information and review factual about what meets and what doesn't meet that requirement. We also have a field training officer program being looked at. What's out there currently, either locally, nationally, who has a functioning FTO program, what are their success and weaknesses, and if that should be something that the state supports and rolls out on a more statewide basis. In the acknowledgement that, you know, we have a crisis in getting people into agencies and also in then indoctrinating them, training them for longevity and for retention. So hopefully the field training officer can fill some of that void. Lastly, we had Niagara Community College submitted a request for AEMT practical skills exam modification. That was passed to the committee from the Bureau. It seemed as though after a lot of discussion, as long as the modification is as stated and nothing further for the time being, the committee is supportive of that. So the Bureau will be responding to them that their modification request should be granted for the one time they're looking to do it, and we need some information back if it worked. Maybe that's something we should look at to move forward. That's all I have. I'd be happy to take any questions. We don't have any seconded motions.
Any questions? Okay, thank you for your report. EMSC, Dr. Cooper is out of the country, so Amy, we were good.
Thank you. For the record, Amy Eisenhower. Ryan took part of my report, so I won't rehash. No worries. Rehash the grant specifics. I will say, though, that the new EMSC grant for the next 4 years has similar performance measures, which is pediatric recognition programs, pediatric emergency care coordinators, and then disaster preparedness. And as soon as I get the official performance measures, I will be happy to share them.
Can you touch briefly, as it probably affect to a certain extent everybody on this committee, the how the hospitals are going to play in the
Yes.
new grant?
It's at the bottom. As Ryan mentioned, we did have our EMS-CAC meeting last week. And we talked about the grant. We talked about EMS for Children Federal, so the EIIC has a Pediatric Readiness Quality Collaborative, and they're currently enrolling for that. So it's a QI program, and they really are helpful. They go through everything. So if you're just starting out and you want to do QI, don't worry, because they really do a lot of webinars and preparedness and helpfulness. And so if you are interested and you have questions, please let me know. They're enrolling through June. We discussed safe transport of pediatric patients and what has been ongoing since we've now been released back into the world after COVID. And our last meeting, we had a demonstration. I discussed safe transport of newly born patients as well as all other children with the group. And also last week, I was at the Child Passenger Safety Technician Conference, which is put on by the Governor's Office of Traffic Safety. And there were 2 classes, so one on safe transport of pediatrics at large, which the room was full. It was very well attended, lots of really great questions. And then I also talked about safe transport of newly born patients. So what do we do after the baby is born? And also really well received, lots of good feedback and questions. So our next EMSC Advisory Committee meetings will be September 5th and December 4th. They will both be here at the Hilton Garden Inn, and that will be from 1 p.m. to 4 p.m. We did discuss some old business, so pediatric agitation education. We are going to continue that work group. In the interim, Sarah Groover, one of our Family Action Network members and a EMS educator and paramedic, has a class on therapeutic communication, de-escalation, and she is going to be teaching that on Vital Signs Academy, and we'll be teaching a component of that at the Vital Signs Conference. So we're very excited to bring that education out for providers while we finalize something more concrete. We did discuss pediatric triage, and I know that that's going to be discussed at length tomorrow at STAC. So that work group will continue. We did discuss reviewing the length-based measuring tapes and comparing that with our protocols for pediatric medications. And I would like to say thank you to, I don't see her, Megan Williams and her paramedic students for doing some of that heavy sifting, lifting, asking questions. So that work is also ongoing, and we will be addressing that and having a nice report from them at our next meeting. Just trying to get to where I was. And then also, as Ryan mentioned, I think last year, the American College of Surgeons made it a requirement for trauma verification that there be a pediatric advocate of some sort. And they use a specific language. However, EMS for Children Federal has worked with ACS, ENA, ACET, all of the letter people, to encourage having a pediatric representative at all trauma centers because, as we know, sometimes kids get brought to adult trauma centers if there's a trauma and they're not close to the pediatric trauma center. So they want to make sure all trauma centers are prepared to take care of children. So they have required having one of those, and in our response, and also in collusion with the new grant deliverables, we have developed Always Ready for Children pediatric recognition program for emergency departments. And then in coordination with that, the person or people, because it can be a team of people, will be the pediatric emergency care coordinators for the emergency departments. So EMS for Children gave their stamp of approval. I will be presenting more on this at STAC tomorrow because they are a large component of that as well. But it's gotten great feedback. A lot of the folks who have reached out to me from hospitals have been looking for this, are very excited to get enrolled. So my hope is to get everything finalized in the next few weeks and then visit RTAC meetings over the summer to share more about the program, encourage enrollment, answer any questions, allay any fears that might come up, and essentially kind of usher the program in. And I think that is most of what we discussed.
Okay, thank you, Amy. Any questions? All right, thank you.
Awesome, thank you.
Moving on to old business. Ryan, EMS Medical Director, where are we with that?
So we are going through the process of trying to get that fulfilled. It has not been achieved yet, but it is actively going through the process with our administrative management group.
Okay, thank you. EMS hospital wait times and diversions. I know in this area it's significantly improved. Does anybody have any comments on their specific areas, how things are going? Wait times, for crews to unload, diversions? Dr. Ayers?
Yes, I agree. I think there's been improvement, at least in my regions as well.
Any other comments on that? Okay. Go ahead.
Sorry, I have a question. So is any region experiencing behavioral health diversion requests, a lot of them? Because we are like daily every day, okay. Behavioral health diversion requests.
Yeah, we have to.
That does seem to be a problem.
Can I-
locally as well.
Mr. Chair,
Yep.
it's possible for Deputy Commissioner to maybe talk on that topic. He was going to talk under new business related to some things going on, but I think this might be a relevant time.
So I think everybody in the room is aware of the activity that's been going on over at the Public Health Council Planning Committee. So the first work group of the Planning Committee, and there's another one that's being planned for a couple of weeks from now, but the first one that took place was focused on behavioral health. You're probably aware that the governor's budget, she announced in the State of the State that she's putting $1 billion towards mental health. Well, as it turns out, mental health has kind of been priming for this moment, I think. There's a lot of things that have been going on in the mental health area, and so we heard about them at the Planning Committee. Dr. Sullivan, the Commissioner for Mental Health, did a presentation, and it was well received. I would encourage you to contact Steve and Ryan to get the link to the recording of the presentation. It's a 2-hour meeting, so it's lengthy, but Dr. Sullivan's portion begins at around minute 27, 28. You might fast forward to that piece. And here's some of the things that they've been working on. And I had hoped to have a presentation by OMH come today, somebody from OMH come today to do a presentation for you folks to hear about some of the things that they're doing, because quite frankly, I'm just not capable of doing it any justice, other than to say there's a lot that's been going on. So in September, we'll see you in September. And at that meeting, somebody from OMH will be doing a presentation on some of the things that they've been doing in that space to help relieve some of the edges. It's not going to cause mental health cases to disappear completely, but there is a lot that's been happening. The only disappointment I have is that there isn't quite enough staffing. Everybody has heard that there's a staffing crisis every place in all of healthcare and beyond healthcare even. So they have not been able to uniformly create a system across the state. So there'll be some counties that are going to be getting some benefits and some counties that don't, I'm sorry to say. But one of the things that they've got is a home crisis intervention group. And you're all aware, I'm sure, of the 988 number that's out there. And there's a whole list of other things that they've been working on to provide resources to reduce the number of people going to a regular ER. And you'll hear about them at the September meeting in much more detail than I can go into. But it has been happening, and it is happening, and it's going to continue to happen. Some of that $1 billion, we've got in this state about, I think it's 24 CPEPs, and they're looking to increase that somewhere in the neighborhood of 36, 40 CPEPs. Clearly, there are some facilities that are just too small, but the numbers of CPEPs are going to grow, and that's just one of many different tools that they are looking to apply to this issue. For those of you who don't know, CPEP, Comprehensive Psychiatric Emergency something, P. Program, thank you. Comprehensive Psychiatric Emergency Program, in case there was somebody that didn't know, like me, I didn't know the last P. Any questions?
Yes, Dr. Murphy. Are they going to put out a request for proposal for the CPAPs? How are we going to apply?
Too early to tell. We've been having meetings with meaning OMH and DOH together. We have a better connection to hospitals than they do. So that's our role in this, to convene. And we've been working with hospital associations. I think everyone in this room is probably aware of the HERDS data and the amount of data that we've been requesting through COVID from hospitals is pretty impressive. Some of that's going to go away as the COVID goes away, but unfortunately we're going to end up having to increase some of the questions or create some questions as it specifically relates to mental health issues. We need data to decide, I'm saying we like it's our money, but it's OMH's money. OMH needs good data to determine who and where will CPEPs go, who can apply, who cannot apply, so we're too early in the process to figure that out, but that'll be up to them. But we want to know how many behavioral health patients there are in the ED waiting for placement. How long have they been there waiting for placement? How many are children? How many adults? There's a whole list of things that they will need for decision-making. So we're going to be converting some of the HERD's information and data from COVID questions over to mental health questions to better drive decision-making for things like CPEP, but also the home-based crisis intervention center and some of the other things that they're working on.
Dr. Morley? Good afternoon.
Good afternoon, sir.
Didn't think I was going to let you get away with saying something. Just because this is something that's kind of been very near and dear to my heart, and as well as Dr. Cushman, we've been working in Monroe County for quite some time with some of our stakeholders. One of them is, of course, the Rochester Regional Health, Behavioral Health and Access and Crisis Center, which is one of those pilot projects that Dr. Sullivan was on a conference call with us to discuss back about November. The program's been in use for just a little over 18 months. The success of the program is hampered by some logistical issues, not the least of which being the staffing that you mentioned, but it offers an opportunity for an alternative destination to the ED. It is a standalone facility. I know that some of our colleagues in the Buffalo region are also using a similar system, but in Rochester in particular, the combination of mobile crisis teams, regional outreach to both the hospital systems and local government entities, as well as this particular usage of a pilot project, is starting to show some effort to reduce the ED overcrowding. It's still a huge problem, but we're starting to see it. I think our biggest initiative right now is to look at alternative transportation modes. And so that might be something that we might want to approach back with this coalition between OMH and FIPIC, is what alternatives to the ED, but also alternative means of getting people there, particularly for those people who may have emotional crisis but are not otherwise falling into the mental hygiene law, for example, a detention of some sort. So those are some things that we're doing in Monroe County. Certainly more than happy to share our successes with our partnerships locally.
Fantastic. Thank you for that. You just reminded me, something you said, it wasn't specific about insurance, but something reminded me about payment. So when you're talking about mental health, who's going to pay for this is a huge, huge piece to this. And it goes much deeper than that in terms of how much are they going to pay, because is it going to be sufficient? So when the presentation occurs in September, or should you go watch this video of Dr. Sullivan, there's a point in there where somebody asks the question about payment. And I really, really want you to pay attention to her response. Some of the things that are going on in this space right now are not insurance dependent. They're insurance agnostic, as in the state is paying for them. So we don't give a damn about whether insurance wants it or not today, but we hope that it'll be identified as having been successful, and then, we'll be looking for them to pick it up. And there's going to be a lot happening in this area in the coming years. We've got a very aggressive legislature interested in this topic, and pouring $1 billion into it's going to get even more attention, for better and for worse. So I think that you pay attention to this space. There's going to be a lot happening.
Any other questions for Dr. Morley? Dr. Daly?
I knew I couldn't get by without Steve.
No,
Oh, Steve just put his mic on and stopped.
After you, sir. So, Dr. Morley, one of the things you talked about was
Could you speak into the microphone?
Yes, sir. One of the things you talked about was the Public Health Planning Council. I know that we've had members from this body go over and speak to the Public Health Planning Council in the past, but this is the advisory board when it comes to the Commissioner on emergency departments as well as EMS. And my suggestion would be that if we can carry it back to the Public Health Planning Council and there's room, I would suggest that the chair of this committee and potentially the chair from the State Council be considered as potential members for FIPIC, particularly around issues like this, where we get the idea that it's ED overcrowding when it really is hospital overcrowding, and ultimately it's a significant component from mental health as well that's impacting our emergency department and emergency services.
So I appreciate the comments very much. I want to highlight that that it's statute that determines membership to FIPIC. So it did just increase by 2 people. There's another bill being moved forward or being advanced to the legislature at this point to add a 3rd position to the council. So the only way that you can increase or get membership on the council is through statutory authority. So we hear what you're saying, and we have no dog in the fight, so to speak, but would welcome more input from folks. So, Professor Kroll.
Good morning, Steve Kroll. I just wanted to respond to the question Dr. Marshall did ask right before you spoke. Behavioral health diversions are a continuing daily occurrence here in the capital region of New York State, where hospitals have to close down. They're accepting behavioral health patients, especially, and pediatric is, is part of that crisis too.
Thanks, Steve. Any other questions for Dr. Morley? Okay, thank you very much for the presentation. Dr. Murphy, you wanted to speak about iGel.
So I just wanted to give everybody follow-up. We started the pilot project and we went statewide. We have 95 agencies that have applied. 40 have completed their training. And as of this date, we have 19 insertions. Just to give you an update, there was some issues with the data moving forward. I don't know, David, did you want to speak to that? Or? So we've refined, and they worked hard over the last 24 hours to work through those lumps and bumps so that hopefully the data will flow much easier.
Thanks, sorry about that. Huge shout out to the DI team. We worked out a really good process in getting the data to us for all the insertions across all the agencies, across all the vendor platforms, and we're going to be getting weekly updates of that information. We can send out some analyses of that to the group if you so wish, but much thanks to the DI team for all of their work in getting the data to the Hudson Valley region.
Thank you.
Any questions for Dr. Murphy? Great project. I'm glad it's going forward. Any other old business anybody would want to bring up?
Just one other thing on the iGel project.
Sure.
We were able to map the iGel project on where both applications have been received from, as well as the ones that have completed the application process. And I don't know if that was uploaded into Portable, but that is something that we've completed and can share with this group as well. If they're interested, you'd be able to see a little bit. It doesn't have names, it's just dots on it, but it is actually pretty nicely spread out around the state, which is exciting to see. So that is something that, again, the DI team was able to put together and we can share.
Thank you, Ryan. All right, moving on to new business. Dr. Daly, you have some new business, I understand.
So historically, many of you may remember a few years ago, Mark Gestring and I from the STAC, University of Rochester Trauma Program, did a lot of work with the Center for School Health around some concerns that the education department had with the use of hemostatic dressings in school stop-to-bleed kits. These kits are being promulgated, as you know, because many of you are instructors, across New York State. They're being promulgated in schools. They're being used by our law enforcement officers. And quite frankly, they're saving lives and they're doing a fantastic job. The education itself is spectacular. The reason that we needed to get involved a few years ago was because of concerns from the education department that indeed hemostatic dressings could not be used without a patient's specific order, and a non-specific order could not be issued for the use of these devices. We had a number of long conversations, worked very well with a group of professionals at the Center for School Health and at Education, and in 2018 we thought this was resolved. No good deed goes unpunished, and in 2023 it has resurfaced. It resurfaced in a document released by State Ed
called Guidelines for Managing Emergency Healthcare and Communicable Diseases in Schools. And it talks about recommended procedures around Stop the Bleed, offers example commentary about training programs, and then has a footnote at the bottom that says, all medications administered in school require a patient-specific or non-patient-specific order. See New York State Ed Guidelines for Medication Management in School. Hemostatic products are considered over-the-counter medications by the FDA and therefore require a patient-specific order for physicians to order and for nurses to administer. They do not fall under those medications that may be ordered, dispensed, or administered under a non-patient-specific order in New York State. Notably, Education Law 6909 says that nurses may receive non-patient-specific orders. Education Law Sections 131 and 139 are specific to what non-patient specific orders can be, including things like immunizations, PPD placement, HIV testing, treating opioid overdose, which we worked on again around the same time frame. This, of course, raised lots of concerns from members of the stack, and we'll be discussing it there tomorrow as well. The Commissioner of Education can issue an order that says that this can change, and this can be added to the list of non-patient specific orders that would be possible. The Commissioner of Health could have a discussion with the Commissioner of Education to promulgate this and may be able to assist us with moving that forward. Dr. Morley, I'm glad you have the chair at the table right now. Hopefully you can help us move this forward. But the concern that we have is right now we have well-meaning school nurses who are being told that their licenses are at risk if they use product that we are putting out there for use by the public in the course of providing emergent care to a child in need. And that, to me, is morally reprehensible and something that we need to do everything we can to correct because it just doesn't make sense. The thing that carries this even farther to a level where we can all get really crazy about it is that hemostatic dressings aren't actually considered a medication by the FDA at all. They're a Class 2 medical control device. We'll add that the LifeVac that we were talking about earlier is also a Class 2 medical device. And another Class 2 medical device that many people are familiar with are tampons. So I think that there's an opportunity here for us to work with education in order to normalize and more appropriately allow our school nurses to provide stop the bleed care when necessary, use the things that the tools that we have put out there for the public and those nurses to use, and make sure that our schools are as safe as possible and our school nurses can feel comfortable with providing the care that they can quite ably provide.
Would you like to make a motion so this body can vote on that and recommend the commissioner address that with the Commissioner of Education?
Yes, please. I would ask that the Commissioner of Health work with the Commissioner of Education in order to assure that indeed our school nurses have a non-patient specific order for the use of hemostatic dressings in schools.
Any second of that motion?
Second.
Okay. Any discussion on that?
As part of that motion or recommendation, would you be able to put together a 1 or 2 page document summarizing it and maybe highlighting some of the things that you spoke about here? I will tell you, the commissioner reads a lot and in detail and normally has many questions. So I think a nice summary of something that puts that together would be extremely helpful. Thank you.
I just have a quick question, maybe you know the answer. So in a life-saving emergency, we don't need consent for anything. So why would we need a patient-specific order to apply a device during a life-saving emergency?
That's a fantastic question.
Oh, thank you. Thank you. I ask good questions sometimes.
Cushman, that's actually, I think, my point of this, which is this body should not be recommending that the commissioner recommend a non-patient specific order for something that is over-the-counter, the right thing to do for our patients. Because I'm pretty confident, I know my school nurse hands out tampons. I'm not aware that that nurse has a non-patient specific order to do so. And so my greater concern is that when we start doing that, we continue to set precedent of stupidity, that we have to continue to identify something that is the right thing to do, that is within the scope of that licensed practitioner to be able to deliver, that what's next? I don't know. So we need our nurses to be able to do this without concern. But I'll be honest, I'm not sure having a non-patient specific order for something is the best long-term solution to the current problem.
So this falls into that interesting area where there's ed law and there's public health law, both covering similar interventions. The use of naloxone was actually something that was very interesting to many of us that were moving this forward, in 2013 through 2015, as we had additional opportunities to train the public. And we went and trained people in schools and said, okay, everybody in this school can now use Narcan except the school nurse. And then ed law changed, and then there was also a section of Article 30 that changed. And keeping these in parallel becomes extremely difficult because there is just so much code. I don't have a good answer for how to make sure that when we have another opportunity that presents itself as a type 2 device, that we can allow our nurses to use this with impunity. I think we will just continue to have to play almost regulatory whack-a-mole with it.
Yeah, hey, it's Winslow. I just wanted to say that you have to give them some kind of guidance if this document is out there saying that there's a concern. I kind of agree with both what Jeremy's saying is what is the right mechanism of granting that nurse that comfort zone to use it if needed. And I'm not sure if it's more of a statement or if it actually has to be a following along the lines of the naloxone where you actually have to have a non-patient specific prescription, but something needs to be stated so the school nurses feel comfortable and they're not confused with what's going on in the document that Mike shared with us.
Any further discussion on the issue? Okay, it's up for a vote. All in favor, please raise your hands. Okay. All against? Any abstentions? Okay, motion passes. It'll be brought up to SEMSCO as well. And Mike, if you could put together one page that Dr. Morley requested. Okay, moving along. Last on the list here is Assembly Bill A5663. Dr. Winslow, you put together a nice reply to this. If you want to mention anything on that. It's the bill A5663, if all of you are not familiar with it, it was a bill that's up in the Assembly, but my understanding hasn't gone anyplace. And it's regard to criminalizing injecting a person with a substance without their consent. So Dr. Winslow.
Yeah, so this garnered a lot of discussion. Realized there is also no companion bill, so it will die in committee. But I do think it's going to continue to come back. This is what, the third year in a row this person has brought this forward. So I was thinking that the group should make a statement, maybe that would prevent it from wasting time next year's assembly, that this is just absolute garbage. That's Winslow, sorry.
So I do know FDNY already sent a letter, I believe, out opposing it. Since your letter hasn't been vetted, I can't put it up on the screen, but if anyone would like to see it, I'm sure he'd be more than happy to share it with the group and send it to your representatives.
Yeah, I crafted like a draft frame of a opposition letter, pretty much stating that, a couple of things were concerning to me. One was that they make it a criminal act. That's the garbage part for clarification for those watching at home. But the other issue is emergency medical care is given every day, and what defines life-saving? Many EMS providers give care that is not an immediate threat to life, but that isn't well defined in the statute that they're discussing. The other issue is one of consent. It states in the very title of it, without consent. We all know how tricky that can be with issues of capacity, which is a medical determination, issues of implied consent, et cetera. So there are a couple of things in the letter. If you'd like, I think I sent Val a copy. Could we use that mechanism to redistribute it to the members, and then they could just review it on their own and share with their own constituents?
I assume we can probably, Ryan, we could put it up on Boardable, could we not? Yeah, so it could go up on Boardable.
Sure.
For everyone to see. I mean, unfortunately, I think it was a well-meaning bill that has absolutely no basis in medicine whatsoever. Okay, any other new business before we adjourn? And I give you back 20 minutes. Okay, can I have a motion to adjourn?
Motion to adjourn.
Any seconds? Okay. All right, all in favor? All right, we'll see you folks on September 13th for the next SEMAC meeting.
call the meeting of SEMSCO, May 10, 2023, to order. If we could all stand for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. If you could remain standing for a moment of silence for our departed members. Thank you. Could we have the roll call?
Allison Burke. Stephen Cady. Scott Clark. Dr. Krupe.
Here.
Mark Devers.
Present.
Don Duval.
Here.
Michelle Fornes. Here. Carl Gandolfo.
Carl Gandolfo, present.
Gregory Gill.
Here.
Jason Haig.
Jason Haig, present.
Teresa Hamilton.
Present.
Donald Hudson.
Hudson, present.
Dr. Isaacs.
Isaacs, present.
Al Kim.
Al Kim, present.
Steve Kroll. Andrew Knoll.
Andrew Knoll, present.
Jared Cutson. Alan Lewis.
Al Lewis is present.
William Masterton.
William Michael Marston, present.
Mike McAvoy.
McAvoy, present.
Elizabeth McGowan.
Elizabeth McGowan, present.
Mark Philippi.
Philippi, present.
Mary Ann Portoro.
Marion Petoro, present.
Dr. Raybridge.
Raybridge, present.
Dr. Redlener.
Redlener, present.
David Simmons.
David Simmons, present.
Carla Simpson.
Carla Simpson, present.
Christopher Smith.
Christopher Smith, present.
Chad Smith.
Chad Smith, present.
And David Violante.
David Violante, present.
Roll call complete. We have quorum.
Thank you. The minutes from the February 8th meeting have been posted. I would take a motion to approve those.
Carl Gandolfo, I'll make the motion.
Elizabeth McGowan will second.
Any discussion, corrections? If not, all in favor of approving the minutes, signify by raising your hand. Any opposed? Any abstentions? One abstention. Motion is approved. Correspondence. I had a couple of pieces of correspondence which I was copied on that were basically pertaining to the budget, and I passed those along to the Commissioner's office to send up to the Governor's office, and so I'm not going to read those here because that already has been done. Chairman's report, a couple things I want to mention. First, thank you all for taking your time to be here the last day and a half, 2 days actually, for some of you longer. Really appreciate your time and your commitment to state EMS and everything that you do. I want to mention to the folks that are sitting around the room at the other tables that there's an open invitation for you to join committees. So we spoke to a couple people that have been attending for a while and sitting in the peanut gallery and learned that they weren't aware that they could actually be on a committee. So if you have an interest in serving on a committee, you have people at home who are interested in participating by serving on a committee, please let myself or Ryan know so that we can get you involved in that. We certainly would like to expand the participation in our various committees. Some decorum, just from looking at the meetings yesterday, at this table are people who are participating in the meeting itself. So if you're sitting at this table, you are a member of today SEMSCO, earlier today SEMAC. yesterday the various committees. And if you're not on one of those committees, then you should be sitting in the aisles or rows that are around here. So something just to keep in mind. It confused some folks yesterday about who was sitting around the table and who was actually on a committee and who wasn't on a committee. I'll mention, and Ryan will probably reiterate this, the EMS Memorial is coming up in 2 weeks, and it'll be at 11 a.m. At the Empire State Plaza. There's some information posted on the Bureau website about that, and if you're bringing a vehicle, Valerie needs to know about that ahead of time. And I will also call out Doug Sambrook for an amazing email that he sent me shortly after our last council meeting, complaining about one of the requirements that we had set in training and ed for hazmat awareness training, and offering a solution to what he considered to be an inappropriate class. And I love to get a message from somebody criticizing something with a solution to their problem. And so I passed this along to training and ed, and they're working on making an adjustment to that. But I think that's a model for everything that happens here, is have a problem and a solution. I also obviously have heard the discussion at the various committees on the Part S, and we really have some very significant things that were in the approved budget. A significant increase in the power and the duties of this body, a significant increase in the power and duties of the REMSCOs, the development of performance standards, not only for EMS, but for emergency medical dispatch as well, that needs to come from this body in conjunction with the REMSCOs. Some accountability through those various standards, a recruitment campaign that's funded now to take place over the course of the next year or so, mental health and wellness training and mental health and wellness activities for our responders, and members of volunteer ambulance services able to participate in the state health insurance system, as well as a big jump in Medicaid reimbursement, which Rich Brandt just talked about a little while ago at the SEMAC meeting. So there's a lot of work that needs to be done here. We have a meeting of the executive committee scheduled next week to talk about how the various committees will pick up some of the parts of that that need to be developed. And they need to be developed quickly because there's money behind them that needs to be spent. So that was quite a victory for EMS in the state. We'll talk a little bit later about some of the other components that were in Part S that didn't make it. But I think it's important for this body to recognize that this is a collegial effort between the REMSCOs, the SEMAC, the SEMSCO, and the Bureau in order to get these things accomplished. And that's the way it's spelled out in the legislation. Bylaws. I put some bylaws up on Boardable for people to consider. This came from a suggestion from our parliamentarian at the last meeting, since the Bylaws Committee originally started working on this about 6 years ago, came up with a final product about 4 years ago, went to the Division of Legal Affairs, and then crickets for 4 years. So we pulled those out and put them on Boardable so that we could discuss them and vote on them today. And lo and behold, I got quite a lot of comments from Division of Legal Affairs about the proposed bylaws, as well as was informed yesterday that the state has templates for councils that can be used for their bylaws. And this is a level 1 council. SEMAC is a level 2 council, and they have templated bylaws that could be used for those councils. And so what I'm going to do is propose that we not table, but postpone action on the bylaws until the September meeting. And I would like to create a interim bylaws committee to look at all this information that we got from Division of Legal Affairs and DOH. And I would like to voluntold Mark Philippi Dr. Marshall and Terry Hamilton to work with me to get that done so that we can deliver to you in September a better proposal than what is currently on the books. So I don't know if it's appropriate to vote on that now or save that for new business, but that would be my motion.
On the mic.
Dr. Langstrom said you could consider this to be the first announcement of a bylaws change.
Right. And you can put me on the committee as well, if you'd like.
All right. Lastly, Michael Quinn wanted to say a few words. He's represented FASNY on the State Council for many, many years. This is going to be his final meeting with us, and he thought he would take a couple moments to say a few words.
Thank you, Mike. I was appointed to this council in 1989 by Dr. Axelrod. The meeting that we had was a walk-up on a warehouse in Fuller Road. It was not accessible to the handicapped unless you carried them up the steps. There are approximately, looking around this room, there's approximately 300% more people in this room than there was in that room, okay? And in fact, staff members, I think if you count them all up here, they outnumbered who was part of the meeting at that time. Okay, I've enjoyed meeting with all the people over the years. I've been either on the council or an alternate for most of those times. And one of the primary things that got accomplished when I was initially on was the 1992, what is it? 1992, if you look, we even printed and handed out the copies of that. Okay, revision. Because of that revision, there is now a SEMAC. There are a lot of other things, such as minimum standards. One of FASNY's primary thing was if you're going to set minimum standards, you had better have a dedicated training fund for the people. That is in there, okay? Other than that, I've enjoyed working with all of the various people, and sometimes people get the wrong impression of what's going on. Quite a number of years ago, we had a little bit of a contention on a piece of equipment that was supposed to be carried on ambulances. And a lot of discussion came up on that. And I made a motion, which got carried. And as we were leaving the meeting, one of the physicians said to me, "Why do you firemen care about the proprietary ambulance people?" I said, "We're all in the same business," okay? So wherever you go, whatever you're looking at, just remember, we're all in the same business. We got to look after each other. Thank you.
Thank you. Thank you very much for your many years of service. First Vice Chairman. There he is. Do you have a report?
No report, Mr. Chair, just, again, a huge amount of thanks to Michael Quinn for his years of service. He's certainly been a mentor to me, both at SEMSCO and at the FASNY EMS Committee, and his knowledge that he has and that he has passed down is absolutely priceless, and he has done a phenomenal job over his multiple decades of service to fire and EMS, both in New York State. So, again, thank you to Michael Quinn.
Thank you. Second Vice Chair, David.
No other report from me as well. The items that we had talked about in previous committees, I think, will come up for discussion in relation to CS waste issues that we've noticed in the Hudson Valley and maybe around the state. But also, thanks to Mike, he comes from the Hudson Valley. He's done a lot of work for us in Dutchess County especially, and for all of his work over the years. Thanks again, Mike.
And then EMS staff report, Ryan.
Well, you went through some of it. I appreciate that. And I know now not to go into Amy's things because she'll talk about her topics. But I just want to say thank you to everybody around the table who was a part of, Part S and providing feedback and just everything that went with it. It's an exciting time for EMS. It's an exciting time when we look at, the EMS sustainability study and, what has come out of Part S, and what made it into the final legislation. We are continuing to move things forward. When we look at Part S and we talk about, many of the new things that are expectations, the expansion of roles and responsibilities of the SEMSCO, the expansion of opportunities and things for the REMSCOs based on SEMSCO's requests. And, there are many just really exciting things. We talk about recruitment and retention, mental health and well-being, which we all know is a big one. And, the system and agency performance standards. And I know I've spoken about this a lot in the past 2 days, but there are a number of people who are hopefully joining us from home or at work. But the system and agency performance standards really has the ability to do so many things in such a positive way. It has the ability to look at where sustainability is needed and add sustainability or benchmarks into it. Looking at things from a system point of view, looking at agency point of views, understanding that if an agency, can only get out 20% of the time, that affects the system. And is there a standard or performance? And sometimes that performance standards helps an agency improve too. Maybe they need to go to a town or a locality or somewhere else to help with, to meet that standard or to get that benchmark. But without that standard being there, they may get told, well, do the best that you can. So setting standards can be a really positive thing in being able to move a system forward as well as have that system unity. And so going through this past 2 days, talking to each of the committees, having each of the committees look and say, okay, what do we think would be helpful system and agency performance standards that will help move us forward? These are things that, this terminology is just getting there. When we look at it and we start to think about it, between now and September, keep thinking about it. Keep thinking about what that would look like. If you're watching and you're not here with us today, please, get those ideas to your REMSCOs who will bring it up to the SEMSCO. This is something that has the opportunity to really grow over the next couple of years. And hopefully we'll start small and then, move it up. And that, in the beginning it might seem like, oh, well, these are such, big lifts or things like that. And then over time you realize, well, these aren't that big of a lift at all because they've become, to the norm. Mike just brings up his years of service. And by the way, thank you, Mike, for the incredible years of service on that one. But he also talked about, what got us to having a SEMAC, what got us to setting other standards and minimum standards on training, and the funding behind it sometimes too. So as we look forward to this, I think there's a lot of great things. I want to, obviously thank everybody here who helped make this happen. Thank the governor's office, for making this a priority on the budget, as well as, everyone else who helped, make this come to fruition. In addition to the system and agency standards, as well as the recruitment and retention and mental health, there's an EMS task force. In the EMS task force, we've learned over the past couple of years that when you need something in time of a disaster, you need it. And it's not something that, the longer you wait for it, it becomes more challenging. We've also learned in state world and county worlds and local municipalities, we can't just do things on, doesn't tend to happen quickly. Sometimes it's even days when we want it to be hours. And so being able to now put together a state EMS task force that can respond to disasters, that can meet those community needs in hours opposed to days. We look at the Buffalo snowstorm and things like that nature, where there was an opportunity to provide more resources and things. And we look at counties that had EMS systems, fold overnight, and what do we do for, a system in order to help in a short term to get something more stabilized into it. Task force and things like this are all opportunities to move forward. And we'll do that through a network of providers, through the agencies that are out there right now, through partnering with them. And picture 50 ambulance services around the state, each saying, I'll accept payment for readiness. And then when the time comes, we have 50 ambulances that we can pull at any moment. That's huge. That is changing the way that we look at things. It's changing our ability to be prepared. God forbid they're actually needed, and be ready for it. And reality is, there may be things that are even a bigger scale that need more than that. And that's when we would turn to our federal partners and work to bring in the national ambulance contract if we had to. But this allows us to be faster, more responsive, and ready, and we keep talking about readiness, as we move forward. The last one, and again, same thing from last time, I don't have too much information on it, but added in, very exciting though, is the health insurance eligibility for EMS ambulance agency members. And this is one that we're going to have more information by September, but it's offering the opportunity for agency members to be eligible for health insurance and to have another option. And we talk about EMS sustainability and what adds to that. We want to make sure that the people who are providing the care to so many also have a way to take care of themselves. And so really excited to see that one in here as well. There are 2 regulatory packets that are in. Hopefully will be out for public comment this summer. That's the education one, based off the Education and Training Committee recommendations, and the operations one, which is the equipment ones. On the education ones, I just want to echo what I had said before. There is an executive order that is in place today that talks about certification and reciprocity, or allows us to do things that otherwise by regulation would not be allowed. If the executive order comes to an end, many of those things would have to pause until the regulatory changes, saying to get approved as is, go into effect, because you can't do certain things. So just keep that one in mind. If the executive order 4, which is safe staffing, the staffing crisis, expires, there are certain things that would get limited. One of the big ones would be you would have to take only the state EMT exam or paramedic exam. You wouldn't be able to take the state or the national and obtain certification. So just keeping some of those things in mind. On the administration front, we continue for the contracts and to make payments. We also, again, encourage all of our REMSCOs and our program agencies to please, make sure to get out there and, when it's time for invoicing, to get your invoices in a prompt fashion and on time. It is a situation to where we get an allocated amount of money, and it's a use it or lose it. So we want to support each of the regions, our program agencies and our REMSCOs. But last year, we were in a situation where not all of it was spent. And so hopefully in the future, again, timing on all of that would come through. There's a multitude of issues on why some of that didn't happen. But again, the importance of that one. So your program agencies and your REMSCOs, please make sure you submit. We also have a position that's open. We have one that's up on our state site, and we have a couple more, hopefully, that will be coming in the near future as the department continues to level set after a number of retirements that have occurred. We have the education, and we have 2 new education policies. They're both up online right now. One of them increases EMT training and CFR training by about 15%. This is the first time that EMT training has increased, I think, since 1999. Yep, I'm getting Mickey shaking her head, yep. And this is hopefully the first of 2 initiatives to increase funding. The second initiative is we are working, and this increase happened working with the Finance Committee and Steve Kroll and his team. We will be doing a second meeting with them to increase funding and to reevaluate that. But we've also asked the Finance Committee, where's your focus? Where do you want to, if the funding is there, increase that funding? Is it focusing it purely on original classes? Is it focusing it on alternative training like leadership training and quality assurance training? So they'll be working on that one. In addition to that, we have 4 new pilot programs in the education world. One is EMT Academy program. This is an increased reimbursement rate for an academy-style class. This will now be offered to every course sponsor to teach one academy-style class at the new rate, and up to 40 students. The second one is the EMS internship program. This is hopefully to help with recruitment and retention. It's the ability to have a local EMT internship program, community internship program where a person who's not a member of your agency can come in, can get involved, do 8 to 12 hours of some sort of participation, learn about EMS, and then the agency would be eligible to sign their training fund paperwork for them. So again, another opportunity. Hopefully, when they're done with their training, they circle back around. This comes from feedback. This comes from feedback from several different volunteers, from some of our instructors who have pointed out, sometimes it takes a couple months to get in. So what can we do to help that? Well, one of the things we can do to help that is to offer them the ability to get into class sooner. They don't miss an opportunity, a training opportunity. The next ones are Intro to Paramedicine. This program is only open to paramedic course sponsors, but it's the opportunity for paramedic course sponsors to do an EMT CME refresher program with a twist of paramedicine into it. So that person who's thinking about, becoming a paramedic, they're not sure if it's for them, and they're trying to figure out, well, what do we do? And would be able to go to this. They'll gain the hours they need for their refresher, but in addition, they'll get to learn a little bit more about becoming a paramedicine. Maybe it's the anatomy and physiology. Maybe it's some of the med math that would have to be learned. Maybe it's a rotation or two, exposure. This actually came from a meeting, not even a meeting, a stop-in at an FDNY station. And while sitting and talking and asking, hey, what can we do better at the state? I happened to ask 2 of the individuals who were there. I said, well, when are you going to paramedic school? And they said, well, I'm not sure yet. I said, why not? They said, well, I'm not sure if it's for me. I'm not sure if it's too hard, if it's too rigorous. I wish there was an intro class. And I said, huh. Then I got to talking, and I got to talking to Megan from BMCC and talking to a little bit about, what do you think of this? And really just stemming that. And so we're excited to put this out there as a pilot and to watch. Does it, convert it? The other interesting part about this is it's designed to help people who want to go become paramedics, but maybe there are some people who are EMTs that don't want to become a paramedic, but want to take a different, EMT refresher class. They want to learn something different. They want a little bit of a twist to it. It will give another opportunity for that as well. And so hopefully we'll get some feedback on that one. The last one is the leadership training. There's a 2-day leadership training that was created for the state. There's a 3rd day on recruitment and retention. There will now be funding behind it. On the education front, in addition, PSI, which is our testing company, now has group scheduling. We have about a dozen course sponsors who are participating in our testing with that one. Once that gets online and running well with them, we will expand that beyond those 12 course sponsors. There's a new ADA process for readers. So we've never allowed readers in the past for the state exam. We are paralleling our state exam with what the National Registry is also allowing, which under very specific ADA regulations does allow for readers as long as they meet the criteria. That criteria is not evaluated by the Bureau. It is evaluated by the Department of Health's ADA office. So the student would submit their paperwork via the portal on the EMS forms page. The ADA office immediately gets their paperwork, and then we'll work with the student in order to determine what accommodations would be reasonable and would be permitted. So it's not just anybody who wants to have a reader, it is people who have the specific learning disability and the plan in place that would allow them to have that. Last week, Data and Informatics met for about a week, actually, to work on the schematron and to work on my goal of asking them, can you reduce the complexity by 25%, meaning the mandatory fields? Can you make it more realistic as we're trying to complete a chart, And Chief Brody told me that he might not have made it to 25%, but he got close. And we'll be holding him to that. And the next year will be the other 5% if he doesn't get to 25%. So this is from feedback from everybody here. It's also from feedback from our vendors as well, who, the EPCR vendors of the complexity sometimes of the New York State schematron. We are working to do our best. But we're also trying to balance that with, having good quality data come in, being able to do good quality assurance and data team and everything else. So the balance of those two. Our next STAC meeting is tomorrow, May 11th, at the Albany Wolf Road Marriott. And tonight, we'll actually be honoring Dr. Marks and Dr. O'Neill, who was the chair and vice chair, who unfortunately passed away within a year of each other to unfortunate situations. So we'll be honoring both of them tonight. EMS for Children, I'm not going to talk about because that comes up later, and I got the look before from Amy. Vital Signs is October 17th to the 22nd. The program is being finalized right now. We're very excited to announce our speakers and everything else. The pandemic, we definitely saw numbers go down, with the pandemic. We're excited to be back in Syracuse, one of our most popular spots to be for Vital Signs, and we hope to see those numbers go up. About 70,000 providers. We'd love to see north of 1,000, joining us this year, and we really are putting together a great program for that. We also always welcome, feedback, comments, thoughts, suggestions on what people want to see, what would attract them to coming to Vital Signs. We'd love to hear that as well. The EMS Memorial is just 2 weeks away. It will happen on Tuesday, May 23rd at 11 a.m. at the Plaza. And like the chairman said, if you plan on bringing a marked vehicle, please let Valerie Osga know so that we can get you access to the plaza. All regular vehicles can park underneath. We spoke about that. The Rural Health Task Force met last week. Really great meeting. We're going to have a formal report out for them. And actually, Mr. Chairman, if you want to tell us where you'd want that to happen in the September meeting, maybe in a subcommittee or at this, that would be great. I think there will be some good things to update by that point. The EMS forms page is continuing to grow. We will not accept paper for almost anything anymore. We've put it all online, and we appreciate you using it. We are just about at the point where we will start returning mail to you if we notice it coming in multiple times via mail, because it all comes in electronically now. So please, use the portals, use those forms. We really appreciate it. And we are going to add a new thing. It came out of one of the meetings. We're going to add a new form on there for policy feedback. So we know we have many policy statements that are, need some updating on our website. We're going to work on that one. And we encourage you to point out things that you think should also be considered with that. So we'll be getting that up. Give us about a week or two to get that up. And I'll say by June 1st that will be up and running. And please feel free to give that up. And I now want to, I have one more thing, but I am going to turn to OHIP and to Rich Brandt for him first.
Thank you. Thank you, Ryan. Again, my name is Rich Brandt, and for the stenographer, that's B as in Baker, R-A-N-D-T. I'm with the New York State Department of Health's Office of Health Insurance Programs, acronym OHIP, Medicaid. Most of you know me. For those of you who don't, I was involved in EMS for quite a while. I'm in a 10-step recovery program right now. I see my former VEM supervisor is in the room. He can attest to how well I'm doing with that program. He's not paying attention. That's okay. Anyhow, I come here today with good news, I think, and I'd like to share it with you. We were able to secure through OHIP an estimated $36.4 million investment in ambulance reimbursement rates for emergency ambulance transports. And I emphasize emergency. And the way we've done this, let me back up. When I said a minimum of 36.4, that's based upon last year's payer data for Medicaid claims paid. So if there are more Medicaid claims paid this year or the year thereafter, that number will go up from where it currently sits. What we did is we mimicked, we could not duplicate the values because we just couldn't get it through budget. We mimicked what Medicare does, and if I'm over-explaining it, please stop me. If anybody knows this better than I do, please jump in. Every January 1st, Medicare establishes a base rate for ambulance service for basic life support, non-emergency. It assigns that dollar value, or RVU, which is short for relative value unit, of 1.00. It presumes that as the least expensive form of ambulance transportation to provide, which it is. It then multiplies that number times an RVU, relative value unit, that is greater than 1.00. So effective July 1st, and we still have a lot of work to do in-house at our end at OHIP to make this happen on July 1st, but effective July 1st, we are going to implement a similar system. The BLS base rate is being set at 195 for non-emergency. If you do a BLS emergency trip, you can multiply that times 1.28, so 28% more. And the 195 was not chosen at random. That's the average BLS payment across the state right now. If you do an ALS 1, it's 1.52, ALS 2, 2.2, and SCT 2.6. So it should be a significant increase for most providers. There are a few counties that have been fortunate through the years, and it's all as a result of the antecedent practices when county departments of social services set their own rates. And they were all over the place. Since I began working with former Medicaid Director Liz Misa on trying to get basically the ambulance industry on a rate schedule, a fee schedule rather, much like Medicare has, we've tried to bring the bottom up. So there's some counties that are already getting more than this. There's only a few of them. They will not be harmed. No one will suffer a reduction in their payment as a result of this initiative. I don't know what else to say. I'm here to take any questions you have. I'm from the government. I'm here to help. So,
So while you're here, I'm sorry, Chad Smith from Mid-State Remsco. While you're here, I don't necessarily have a question on the emergency transport fee schedule. There is a question that I have on the non-emergency transport GPS requirement for non-emergency medical. Are you aware of that, or?
I am aware of it, yes. Yeah. It is a requirement. However, we have told our transportation managers to grant an extension to any ambulance provider that applies. We feel GPS, and again, Medicaid manages all forms of medical transportation. Ambulance is a small part of our spend, a very small part of our spend. And we know that you're not the problem. Okay, I'll be frank. But we had to make it across the board. But we are willing to grant extensions to compliance to ambulance services who just ask. And put it in writing and send it to your transportation manager. You said Mid-State, be Medical Answering Services in Syracuse. Put it in writing. They'll send you a letter back approving it.
Thank you.
This is a fabulous thing for EMS, and we appreciate your advocacy, which I'm sure was involved in it successfully coming through.
Yeah, I do take credit for being the genesis of this. I did not carry it across the finish line by any means.
Any other questions for OHIP? Rich? All right. And again, I also want to, just put it out there too. I think in a 5-year gap, or in a 5-year period, maybe 6 years at this point, it will be an increase of almost $65 million invested from Medicaid into the EMS field. And so, just again, that focus on that.
That's a very good point, Ryan. Thank you. Going back about 7 years ago, I was involved, the legislature mandated that the commissioner evaluate the adequacy of payments made under the Medicaid system for ambulance service. I was at BEMS at the time. I was loaned out to Deputy Medicaid Director Liz Misa, who's since left state service, unfortunately, for us, not unfortunately for her. She's doing very well. But I was involved in that in between my work with Liz, and over a 5-year period, we were able to bring an influx of about $32 million into the payment schedule. So that was a start, and we're building upon it with this, which is even a bigger number. And this will not be phased in over 5 years as the last one was. This is going to be instantaneously effective for dates of service 7/1 of this year and forward.
Thanks so much, Rich.
Thank you. Thank you for having me. And
Al Kim, I think, has a question.
Rich, thank you for that information. Are you aware if the states will be getting the information shared from the federal CMS data collection system that's happening as we speak?
I know what you're talking about. I'm familiar with that. I don't know. That's a really good question, and that's an excellent question. You're talking about the mandatory reporting.
Correct.
Yeah, okay. Yeah, and that's in phase 2 right now, I believe, at the federal
Yeah,
level?
the phase 1 are due end of May, this
Okay.
month.
Yeah, I don't know if we will get data from that or not. Certainly if we do, I would want to tap into it. I do a lot of the data work for our little unit, and I would certainly want access to that if it becomes available to us.
I know it's been something that's been in discussion, but I don't believe that it's moved forward yet, but we can also, we'll bring that back up as the program took a little bit of a pause during COVID and everything that's going on there. For those who aren't familiar with it, that's the mandatory cost reporting that goes along with anybody who accepts Medicare payments. So, all right, moving on. Just wanted to put out there while we're here, and again, people watching from home, there's a lot of work to be done coming up, and some people don't know that you do not have to be a member of SEMSCO in order to serve on a committee. So, if anybody around the room, the table, or now at home, or at work, or at the front of an ambulance, I guess that's an important one too, is interested in possibly serving as part of the SEMSCO committees, up to 50% of the committee members don't have to be vetted members of the council, and they can send a resume either to myself or to Mike McAvoy and give us a resume as well as some interest of why you want to be on a particular committee, and we would love to see some additional participation as we increase the workload that is required in order to get these many things done. I also want to give a little shout out to the BMCC paramedic students who are watching this live from their classroom right now. They watch SEMAC and now watching SEMSCO. Again, just an excellent opportunity. When we talk about involvement on these committees, many people don't even know what a SEMSCO is. They don't understand what happens at them, what occurs. And so that opportunity for a student to watch and participate, and I believe they are getting some feedback there as well, on what some of the different things are, is an excellent opportunity. So other ideas or things that we can do to help, engage others to be part of their REMSCOs and their SEMSCOs would be wonderful things as well. Last, but far from least, is I just want to give a true thanks to District Chief Joe Farrell, who has served the Bureau for the past 25 years as an investigator and served my corrected number from before, and I apologize, as a certified provider for the past 59 years. And his work has truly been amazing as he both helps his agencies in the area, in the Albany region, and north and south, but also around the state, being one of the lead investigators for annual paperwork that has to come in and your annual renewals. Many know Joe, and there's probably many more who don't realize the work Joe has done for their agency without them even knowing it. And so after 25 years and 59 years of being a certified provider, Joe will be retiring this August before our next meeting, and I just wanted to take a moment to recognize him for his service throughout the Marrow region, the upstate region, and across the state for all your years of service. Thank you so much for everything you do, Joe. We really appreciate it. And with that, that's the end of our report. Happy to take any comments or questions.
Any questions for Ryan? Death threats, comments, otherwise?
Comment. Thank you very much for working very hard to get some increase for the core sponsors. I know it's not all of it, it's some of it, and also addressing the need to allow an alternative path for verification of membership. That'll be monumental for the volunteer service, so thank you.
Yeah, and just to touch on what Mike just mentioned, if you weren't able to join in the Training and Ed Committee and some of the information after, what he's referring to is currently right now in the pilot program will allow an agency to sign for the training paperwork before a person takes a class. So they'd be able to go and hand in the training fund and be able to take a class, and the course sponsor would be able to gain reimbursement. One of the things that Mike has asked us to evaluate is there the opportunity, if a person paid on their own up front, and then they went and joined a volunteer agency and actually showed up as an EMT and says, I want to volunteer, and they finished the class within the last 12 months or maybe 18 months, could they be eligible, could that agency be eligible to submit for reimbursement for them, and then maybe have that be an initiative for them? So essentially, they would get their course reimbursed after they've provided now some care. I think one of the concerns, and a very understandable concern, is they become EMTs, but they don't use it. They don't end up on an ambulance. We know only 50% of our 75,000 providers actually provide care on an ambulance, and so that is, a big factor to, where things are and everything else. And so, great idea. We absolutely will take a look at that. Thank you.
All right. Dr. Doynow, you want to report on SEMAC?
Okay, I'll pass it over to Dr. Marshall since that's a major part of our report.
Good afternoon, everybody. So we have several action items to bring forward, 3 motions regarding protocols, and what I'd like to request, Mr. Chairman, is that we discuss all 3 of them and then have one vote for the 3 protocols as we did in SEMAC.
Brilliant.
So the 3 protocols that are brought forward from the collaborative, the first one is on advanced directives, DNR MOST protocol, and what the changes did was to clarify the language within the protocol itself to make the protocol easier for pre-hospital providers to follow. The second protocol is the adult and pediatric seizure protocols. And for the pediatric seizure protocol, changes include under CC, changing midazolam dosage from 0.1 milligram per kg to 0.2 milligrams per kg with a maximum dosage of 10 milligrams. It also allows for additional doses if the patient continues to seize. For the adult seizure protocol, it changes under paramedic, midazolam 10 milligrams IM or intranasal, and that can also be repeated once in 5 minutes. And it added a new bullet point under key considerations, which describes the flow of administration. So administer midazolam first, followed by magnesium and additional midazolam if required. That's the second one. And the third one is the pain management protocol for both pediatric and adult patients. And for the pediatric patient, it added the concentration of acetaminophen as well as the concentration of ibuprofen, and gives the CC options of morphine and fentanyl in appropriate doses, as well as added new key points and considerations describing what happens if somebody has nausea, vomiting, contraindications to the medications that can be administered under this protocol. That's for pediatrics. For the adult, for advanced acetaminophen up to 1,000 milligrams, and they removed other dosing options, and the same for ibuprofen, which can be up to 400 milligrams. Under paramedic, it also added ketorolac, 15 milligrams, IV or IM, as well as acetaminophen, 1,000 milligrams IV over 15 minutes. Another new addition in this section is ketamine, 25 milligrams IV over 5 minutes or 50 milligrams IM, and it can be also given weight-based up to the dosages I just mentioned. There was some rewording in the key points and considerations and discussions about contraindications for some of the medications that can be administered under that protocol as well. So those are the 3 protocols. They came forward from medical standards and SEMAC as seconded motions. Oh, there's one more.
Type 2 device. Hemostatic dressing. Letter to go to.
Oh, I think we should do that after. Yeah. That's, yeah, 'cause that's.
So any discussion on the three protocols you just reviewed, the DNR MULST, the seizures, adult and pediatric, or the pain management, adult and pediatric? That comes forth as a seconded motion. Could we take a roll call vote on all three?
Scott Clark.
Yes.
Dr. Krupe.
Yes.
Mark Devers.
Yes.
Don Duval.
Yes.
Michelle Fornes.
Yes.
Carl Gandolfo.
Carl Gandolfo, yes.
Gregory Gill.
Yes.
Jason Haig.
Jason Haig, yes.
Teresa Hamilton.
Teresa Hamilton, yes.
Don Hudson.
Hudson, yes.
Dr. Isaacs.
Isaacs, yes.
Al Kim. Steve Kroll.
Kroll, yes.
Andrew Knoll.
Andrew Knoll, yes.
Al Lewis.
Al Lewis, yes.
William Masterton.
Masterton, yes.
Mike McAvoy.
Mike McAvoy, yes.
Elizabeth McGowan.
Elizabeth McGowan, yes.
Mark Philippi.
Mark Philippi, yes.
Marianne Portoro.
Marion Potoro, yes.
Dr. Raybrich.
Raybrich, yes.
Dr. Redlener.
Redlener, yes.
David Simmons. Carla Simpson.
Carla Simpson, yes.
David Simmons, yes.
Christopher Smith.
Christopher Smith, yes.
Chad Smith.
Chad Smith, yes.
And David Violante.
Violante, yes.
Motion passes.
Thank you. So the protocols that we just did, according to our protocol revision process, will be posted in January and effect in June of next year.
Thank you, everybody. We have a couple more motions I'd like to bring forward. So in 2021, I believe the state legislature approved air ambulance ability to carry and administer blood and blood products, and they have been operating under that law. But we, as SEMAC and SEMSCO, have been tasked with developing the regulations using the framework that's been developed by the department and stakeholders. And so we approved unanimously to begin development of these regulations to support this. And there was some discussion about expanding it to ground ambulances as well, and we hope that will happen at some point in the future. But these regulations that we're tasked with developing are essentially for the air ambulance industry at this point in time. So that comes forward as a seconded motion to approve development of blood administration regulations using the framework developed by the department and stakeholders. I think that can be just
Any discussion on that?
If I could, Mr. Chairman, is there a reason why you can't incorporate ground transport also when you're creating these new policies? And I'm confused about that. We sat here for years to try to get ground ambulance to be able to carry blood. We're almost at the threshold of being able to do it by legislative initiative, but we'll have to wait for this group to then, if you don't include ground in what you're doing now, we'll have to go through the whole process again. And as I mentioned, within 3 years, we're losing 600,000 nurses. And it means we can't get nurses to go with critical patients today. Well, you'll be lucky if you can find nurses in your emergency departments. I mean, it's critical, and these patients we're transporting at times need blood transfusions or blood capabilities. Why would we not do them both together? Please explain to me.
Absolutely. So ambulances can carry blood today through the ambulance transfusion service through Wadsworth. The air medical Air Medical had looked at it, and had some complications with that, and worked towards legislation to put into Article 30 specifically for Air Medical to be able to carry and store blood, opposed to just pick up blood from a hospital to transport a patient to another hospital. I think this is in the pathway. I think, as we see success in the Air Medical program, hopefully it would be a shorter road to the ground service. I think your input is very much valued, and also might be something that, as the regs are written, to possibly write it, and this is going to Chief Tripez, in such a way that it is for eligible services, opposed to maybe listing the word Air Medical, so that if legislation is ever changed, the regulations would apply to all that are eligible based on the regulations. Based on the statute.
If I could share with you my experience with Wadsworth in that whole process. As you may know, I sat on my hospital board for 21 years, and I brought the Wadsworth paperwork and what's needed to be approved to the hospital board. They wouldn't touch it. Now, I'm not sure if that's happening across other areas, but it's too cumbersome. So I just ask you to, we don't need to wait 6 or 7 more years for ambulances to carry blood. I'm talking about saving lives, and I know you want to do the same thing, but it seems though we ought to be able to do the same for both. Thank you. Just
Chief Tripez, is there anything else you have on that one? Thumbs up. Excellent. Al, thanks so much. And like I said, I wish it was as easy as turning and saying they would fall under that same legislation. Unfortunately, the legislation is very specific to Air Medical, but I think this is the step in the right direction. I think your words truly can help us in framing those regulations in such a way that they do continue to be any eligible. So if legislation changes, that the regulations would apply to all.
yeah, and the bill, and I'll end this right now, the bill that I'm going to talk about under my report has been passed through the Assembly. So it's waiting for the Senate, and that even gives us more of an impetus to move forward with enabling legislation from this body to be able to do that. So thank you.
Any other discussion on this motion? If not, all in favor signify by raising your hand. Any opposed? Same sign. Any abstentions? All right, motion passes.
Thank you. The next motion comes forward as seconded motion, and this reads, regional REMACs may require all EMS providers who provide EMS care in their region to complete a credentialing process to be determined by the REMAC. There's a lot of discussion on this motion in terms of, the need of the region to know who's practicing within their region, which is real, and the issue of, is it credentialing, registration, licensing, or some other process that credentialing means. And we'd also talked about the definition of credentialing I believe in the national scope of practice definition as well. And then this was approved and comes forward to this body for consideration.
So any discussion on that motion? If not, all in favor signify by raising your hand. Any opposed? 2 opposed. Any abstentions? All right, motion carries.
You want to do it?
Yeah. So the last one that came through as a second motion. Basically, as you folks know, for quite a few years now, schools have been able to use hemostatic dressings without a patient-specific order. Apparently, most recently, this has now become an issue where it's a type 2 device, and there's a concern that without a patient-specific order, if a nurse at a school were to apply that dressing, they would potentially put their license in jeopardy. So essentially at SEMAC, we decided that it would be reasonable to send a letter to the health commissioner to state that this really should be covered under non-specific order. So without having a specific physician order to say, yes, you can apply this to that specific patient, a nurse would be able to do so. Dr. Daly is going to write up a one-page information sheet to give to the Commissioner of Health to discuss it with the Commissioner of Education to resolve this issue. And it came through as a unanimous seconded motion to approve that.
Any discussion on this motion? The humorous discussion was at CMAC. All in favor of having a letter sent to the Health Commissioner requesting they speak to the Education Commissioner about said problem, please signify by raising your hand. Any opposed? Same sign. Abstentions? Motion carries.
Just some items of information. So at Medical Standards, we had a presentation by OHIP, not to be confused with the one we just had from OHIP. That's the Office of Health Emergency Preparedness, and they talked about the KIMPAC plans for the state, the hub and spoke, and how regions need to be aware of where their KIMPACs are and how to obtain them. Also, they talked about the Mark I kits, which are no longer Mark I kits, but as you know, 2 separate auto injectors. And so regions should go back and look at their policies and protocols to make sure that that's included in that as well, and make sure that regions know, how to access their KIMPACs, because it's been done in New York State in the past. We also talked about policy that we approved last meeting regarding, it was an advisory for medical devices used by ambulance services to make sure that the agency medical director is involved in the decision and approval process for any devices used by their agency. This did not include FDA-approved devices, and under Article 30.3002A2C, SEMAC is tasked with developing minimal standards for the use of regulated medical devices. And so we'll put together a group to develop that list. May not be a list of specific devices, but maybe categories of devices that are FDA approved. And we're going to leave the previous advisory the way it is. We also talked about the substitution list. So policy 1304 is a decade old, and some medications have come and gone in terms of availability. One that's not on there is albuterol, which is now in shortage, which wasn't short 10 years ago. So we'll also have a group that's going to go look at that. And I know the department is also working, in general, to look at all of our old policies. I did mention that in 1993 we actually didn't have any, so that was a good year. We also talked about using ISTAT. Everybody knows what an ISTAT is. It's like automatic point of care testing, which is CLIA waived, and so agencies now can use them in special circumstances like rescue medics, but it may be expanded to other uses within this pre-hospital system, so if anybody's interested in looking at that. And then the last thing was wasting of controlled substances, which I think was mentioned already, but there's one region where the health system in the region has decided that they were not going to witness wasting of controlled substances by pre-hospital personnel delivering patients to the hospital. So everybody's agency controlled substance plan should have a process in there which allows witnessing by their own personnel, as well as hospital as well. So just wanted to bring that to your attention, and I'll turn it back over to Dr. Doi now.
Okay, thank you, Dr. Marshall. Just a few more information issues. State EMS medical director is still in the process of being put together. We discussed EMS hospital wait times and diversions, which seem to have improved throughout the state, except perhaps for mental health issues. Dr. John Morley did give a nice talk on what the state's doing and what funding is going to be available. Dr. Murphy mentioned iGel process. So far, they have 95 applications, 40 agencies that are already on board, and they had 19 insertions without problems. Let's see what else. We also had a discussion about Assembly Bill A5663, which some of you may already know. Third time it's been presented to the Assembly. Probably well-meaning, but has literally no basis in medical care and is actually dangerous, where it would criminalize giving a patient a medication without their consent, which would severely limit our ability to take care of a number of patients. And it was recommended that you contact, or people contact their representative to let them know that this is not a good thing. Dr. Winslow did put a letter together that I believe will be up on Boardable if people want to see it, to send it. And that is the end of the report from SEMAC.
Thank you. Any questions for SEMAC or Med Standards? If not, I'll go in between them on the agenda. Three things from Executive Committee that came up this morning. Number one, Terry Hamilton is going to co-chair the Innovation Committee with Jason Haig. And so congratulations, Terry, I think. And two committees we're going to add on to their tasks. The Innovation Committee will become the Innovation and Research Committee. And the reason for that is that there is a plethora of published and unpublished research being done by fellows, being done by paramedics and EMTs across the state, which appear at national conferences, and yet this body really has no exposure to them. So we'd like that committee to work a little bit with the fellowship programs and the other groups in the state, ACEP, New York, NAEMSP, and help to pull some of that stuff into this group so that there's a way for us to be aware of the many, many good things that are being done in the state. Additionally, we periodically hear here about proposals for research, some of which are perfectly logical, such as the iGel program, and others which may not be so logical. And so this gives a conduit for some review of that prior to it appearing here at SEMSCO. Second change is in the Legislative Committee, and the Legislative Committee is going to become the Legislative and Regulations Committee. And with a new discovery by the Bureau of how to navigate the regulation process and get regulations actually into play, this group will have some work to do going into the future to implement regulation changes and regulation updates and that sort of thing, and expand their scope a little bit to get into that whole realm of things that affect us. So those are three items that came up at Executive. And I will move on to education and training. Don Hudson.
Good afternoon, everyone, and to those out in TV land. Feedback here. Sorry, we got some feedback going on over here. So I will review our agenda, which is posted on the state website as well as in Boardable for those members of the Education and Training Committee. Not to rehash too much because it was went over at SEMAC also, but so Director Greenberg went through the very exciting and long overdue educational funding policy. That's a first step in expanding to our core sponsorships the much needed support for EMS education funding, both in original and refresher classes. That'll, again, be a first step in moving us towards a future with increased funding streams and whatnot to support EMS systems, both in recruitment and retention of new providers and refreshing and keeping people in the game, so to speak. Chief Chesney from State Bureau Education went over the pilot programs that have now been held twice around the state regarding the proposed BLS practical skills exam change to a more scenario-based exam rather than individual skills stations. That is coming down the pike, but is months to years away, not days to weeks away. So please don't hyperventilate over anything that may come overnight, because it's not coming overnight. But we'll see what that looks like and form a realistic and sustainable pathway forward to getting people credentialed that way, or licensed, I should say, in New York State. Also, Chief Chesney went over the pilot program for unveiling the beginnings of group scheduling through the current New York State exam provider, allowing course sponsors to schedule, once again, providers for their state exam, rather than us having to wait as course sponsors for them to take it anytime within the next year and possibly not even take it at all, which not only impacts the system with active providers, but also course sponsors for funding, which then is not available. Alternative funding course for EMS courses came about as a discussion, particularly from our SUNY and CUNY collegiate courses, which are aware of through their financial offices that is not available to other course sponsors. Additional course funding potentials for EMS classes, so we'll look for that in coming meetings about whatever potential alternative funding streams might be out there, aside from the current state reimbursements. We have a joint project going on with the Paramedic Consortium involving reviewing the current New York State policy for both CLI and CIC initial certification as well as recertification, looking at what's out there, possible reciprocity with other licensed, credentialed educators from other realms or professions. So look for more information on that. As Director Greenberg also mentioned, we had a well-formatted and timely question come in from one of our core sponsors about hazmat awareness training, which is a National EMS Education Standard requirement for EMT and other certifications, licensures, both original and renewals. So we're putting together a comparative of what's used, what meets those standards, and what doesn't meet those standards. So just to wet your whistle on that, the IS-5A course, which is in use in some places in New York State, does not appear to meet the standard as stated on the FEMA website. So if you're using that, we'll give you opportunities and alternative courses. We do like the words free and online or self-paced, so if we can stick to that, that'd be awesome. So look for that coming. And then lastly, we have a working group looking at putting together an actual field training officer program for New York State EMS agencies' use that would, again, support both old and new providers in getting them onboarded and keeping them active and engaged, as we, again, need every butt in the seat that we can get. So I'm happy to take questions. Let me just close on, like everyone's been alluding to, we want to engage everyone in EMS education, not only current providers, current educators, current course sponsors, program agencies, current students. This is an all-hands-on-deck game and needs to be driven by the people that it's impacting. So if you want to be involved, please reach out to any of us and we'll get you on a committee. We're open to your ideas. We're willing to listen to your problems, but as the chairman said, problems that come with solutions are even better, so please reach out. Thank you, sir.
Thank you. Any questions for Don? If not, I'll move along to Steve Kroll and Finance.
Good afternoon, everybody. We have no seconded motions today, and a lot of what we have to talk about has already been covered by some of our guests, so I can just give you a brief summary. Obviously, we're thrilled about the Medicaid rate increase, and I'm glad that Rich was able to describe that formula for us. I think it's pretty easy for EMS agencies to calculate the change in payments based on the RVUs and see how this will positively impact them for 6 months of this current state calendar year and then for 12 months next year. Similarly, I think both Ryan and Don have described the educational funding increase. The Education and Training Committee and the Finance Committee are working together. And so, as Don mentioned, there'll be some data. We've got a lot of data from the survey that was conducted that Mike McAvoy's been looking at, I've been looking at, Don's been looking at. We're going to bring that data set together with a subset of people that have already been appointed from the Finance Committee and from the Education and Training Committee to make the recommendations to the Bureau about whether or not, what programs that money should go to and how much. And so that should be done by September. And our goal is to help the Bureau of EMS spend all the money in the training budget by the end of the fiscal year, because we sometimes find ourselves in a place where we're saying we need more money for something, and the first thing the Division on Budget does is when the budget request goes in, look and see what you spent before. And if you haven't spent it all, they're not so great on spending more. So that is our second larger project. The third project we're working on is the 2024-2025 budget recommendations. So, you know, the fiscal year is 1 month old, and we are already working on that. We've had 2 discussions of that at the previous meetings, and over the summer, we have to take the information from those discussions and formulate it into formal recommendations to be adopted by the SEMSCO at the September meeting, which is what Ryan will then, what the Bureau will then forward to the Commissioner of Health for our recommendations, specifically in training and education, and then for the funding for program agencies and for the REMSCOs. So Ryan already addressed something in his remarks about the funding for the program agencies. There are some program agencies that don't spend their full allocations on the deliverables. It's important for the program agencies to be cognizant of, if you leave money on the table, it's not money that can be transferred to another program agency. Each program agency has an amount in their contract. But if we have really substantial data provided the program agencies that they're underpaid and that they haven't got an increase in a very long time. It's very hard to be pushing for the next level of increases when there may be money left on the table. So I think it's important for the program agencies. So I think everyone on the SEMSCO should be going back to your program agency and asking them, are we spending and vouchering our full allocation? And if not, ask why. Is there a problem with understanding how to voucher that related to the deliverables? I know that the Finance Committee is going to work with the program agency heads to figure out if we can help any of our peer colleagues at program agencies. But our goal should be, at the end of the year, that we've used 99.99% of the money so that we can go back for more. So we'll be making, I know Ryan is going to, and the Bureau are going to look at the data, see which program agencies we might help a little bit in this area. The last thing.
Steve, can I just ask a question?
Sure.
Yeah. So regarding these contracts and not spending the allocation, could we have the Finance Committee report back to this body, some understanding of the reasons why this money is not being spent? I know we should bring this back to the REMSCOs and the program agencies and ask them why we're not spending the money. I think we should know why the money is not being spent. And maybe there's a training issue, an education issue, maybe there's some help they need from the Department of Health. I think it'd be worth the conversation to have.
I appreciate it, but I'm going to respectfully say that that I think also needs to be a conversation between the program agency leaders and the Bureau of EMS. So I'm Finance Committee is certainly interested in this, but in conjunction with most of the meetings of this body, the program agencies meet. I'm certainly, as a Finance Committee representative, willing to come to that meeting when we talk about it, but I think that the program agency leaders, they're your budgets, right? And so if you're not able to spend them, you should be talking with the Bureau about why you're not able to spend them. And, you ask some legitimate questions. Is it training? Is it vouchering? Is it deliverables? Those are contracts between the program agencies and the state. And so I don't know that the Finance Committee really is a material in the middle of that contract. I'm certainly willing for us to participate in the discussion, but I would encourage the program agencies and the Bureau to really work on this together as well. So I'll do what I can to help from the Finance Committee. But I think, the first line is that, and I mean, we're being transparent about talking about it openly here, right? So each of you that is on a REMSCO now has a conversation you can have back at your program agency about whether or not the money's being spent. And I think the program agency leaders now, have made this known so they can work with us to talk with the Bureau about what their questions are. I imagine if we know which program agencies are not making their spend, we can help them along perhaps in understanding, that I don't know the details of each one, and I know that's the question that several program agency leaders asked me that now we're forwarding to the Bureau to say, can you give us, who's not been able to spend the money so we can look at why. So,
Okay, thank you, Steve. I agree with everything you say. I think it would be useful to know if there's some common themes
Yes.
across agencies and REMSCOs, okay, that maybe we can help with.
You're absolutely right, and the first step was bringing it up here so we can talk a little bit about it more, and, we have over to dive into the details of it. So those are the major things we're working on that were on the agenda. We have one new business item that I'll just briefly tell everybody about. In the interim time period between last meeting and this meeting, the Bureau of EMS asked the Finance Committee to work on a survey, a salary survey for EMS in New York State. This is not a leadership survey. This is a provider-based survey. So we would want as many providers as possible to fill it out, and it'll be sent out electronically, probably disseminated in many different ways. We have the first draft of the survey. We worked on it at the meeting. We'll work on it more over the summer. And the idea here is we have a lot of discussion about EMS providers not getting paid as well as they should be. Well, what is the right rate of pay? And I don't know that's an easy answer to the question, but we're hoping that we can use some data to point to some of the weaknesses in the pay system, what kind of things need to happen to keep people in our field. So it's a salary survey, and it's also, I would say, a sustainability or durability survey. I mean, we're going to be looking at, are you planning to leave because you're going to go someplace else and make more money, and why, and what is that place? So hopefully we can get some more information on that. So that's what's happening at the Finance Committee. And I think we'll have a couple meetings probably over the summer to work through these things, and I'll be glad to answer any questions.
Beth?
Steve, is your survey going to include geographical location and cost of living indices?
It is going to include geographical location, and that geographical location can be then subsequently matched up with a cost of living allocate. We're not going to ask people, what is your cost of living? But if we know you live in New York City, your cost of living is different than, say, Buffalo or Utica or Albany. And so, Buffalo's a really expensive place, Greg. Chicken wing prices, they're through the roof. But that way we can do those kind of comparisons, because I realize that we can't really compare salaries in different parts of the state. But yes, that's going to be included.
Don?
Thanks. Oh, no.
Don Hudson, to answer Dr. Kruppe's, or lend some insight to Dr. Kruppe's question, which is why we hold these open meetings and collaborate so that everyone's aware. So one of the instances of leaving some money on the table, my region didn't have a program agency for 2 years, so that money was allocated in the state budget and was not utilized due to, we were bound by a contract with a company that no longer exist. So, that obviously shouldn't impact any other region, nor should it, in the grander conversation, be held against EMS as you didn't spend it, so we're taking it back, especially since it's beyond anyone's control. But again, it's only by talking about it here and lending those examples to each other about what's working and what's not that we, get stronger together. So I'd be happy to spend it. It was just getting it that was the problem.
Thank you, Mr. Chair.
Any other questions for finance? If not, we'll move on to Al Lewis and legislative.
Are you passing up on Mr. Devers?
Oh. All right, I'll move on to Mr. Devers and systems.
He's just waiting to give his report.
Since you tabled his agenda.
Yes. So I have a really short report, thanks to Mr. Lewis, literally. We're trying to get a kind of tag group to take a look at the new trauma triage guidelines and get some education out to people, and help with some geographic destination decision-making guidance. We had a tag that was working on CONs and the policy statement therein, 0606. We kind of pushed the pause button because of the budget and the CON portion of the budget. Now that the budget's been settled, we'll get that group back up and running, and probably be looking for some new people. We're also going to be starting another group to look at, I guess we'll call them performance standards, system performance standards, that we can present to this committee. And I'm going to be looking, again, for people, so people in the gallery, people in cyber world, you can be part of a committee. Most of those TAG meetings are actually, all of them are online. They'll be all Zoom or WebEx. So if it's something you're interested in, please reach out. And at the next meeting, compliments of Mr. Lewis, and tabling my entire agenda, we will have 5 CON actions. 4 of them are in ALJ at this time, awaiting a recommendation, and they are Scarsdale and Austining. So if there's no questions, my report.
Any questions for systems? I will note that there was considerable frustration with the time period with which the appeal information appeared in Boardable, and we've had some discussion with the department about that, and there potentially is a way for them to accelerate that going forward. So we'll see how that plays out, but I think that should be successful in resolving some of the concern. Mr. Lewis?
Thank you, Mr. Chairman. Well, there's been a lot of healthy discussion about the motion I made, and I think it helps us to move forward and present information to you in a timely manner so you have an opportunity to review it, research it, and make an informed decision at this table. That was my only purpose for doing that. We need to get better at what we're doing. And I appreciate the discussion with the director and the deputy director, and I'm hopeful. These guys know what they're doing. We just got to tighten things up to get it out right. So Part S, I'm going to take a little bit different approach on this. First of all, the Medicaid money is sorely needed. It's closer to 80 million, I think, when it's all said and done, because we worked really hard to get the first 31 point something million, and then this 38.4. That's a shot in the arm. I've been the first to criticize Medicaid and how poorly they paid us. And it's not where it needs to be yet, but it's better. I mean, we need that money desperately. And, you know, the study of wages is being done by Mr. Kroll. And I must tell you, if the ambulance industry were paid more, only paid to the cost of what they provide the service, they would pay their people more, because people are worth a lot more than they're paid in so many ways. Man, they put their butts on the line all the time to provide quality patient care. So I think we're working in the right direction. And I just want to thank not only this group, but the Bureau and a lot of the other people on the periphery here working on this legislation, and Part F before, Part S now. It's not perfect, but it's good. And I think we have more work to do in the next executive budget, the next budget. So we're getting I think we're moving in the right direction. So you probably can tell I'm frustrated about this blood stuff, and we can't put blood in our ambulances. I'm telling you. And I talk to operations day after day after day. They can't get nurses to go with these patients. You know, we got one operation that transports from Watertown to Westchester, critical patients. And all of this exists all over the state. And it's happened for a couple of reasons. First of all, the consolidation of hospitals, the purchases of hospitals. Sometimes that changes the tertiary care centers. And that's okay. If it's in the best interest of patients, I'm all for that. But it takes a real hit on the ambulance industry. When you take that patient from Watertown to Westchester, it's a 17-hour turnaround. Okay, that ambulance is out of service for 24 hours. So that really hurts the community that ambulance comes from. But we're trying to adjust. And COVID damn near killed the industry, I got to tell you. Well, it hurt all healthcare. It hurt our hospitals. It still hurts our hospitals. We just have to work together to make sure we're doing it better. And I can't tell you how much I'm upset about just reading the article that 600,000 nurses are going to leave healthcare by 2027. Wow. I mean, think about that, 600,000. And we can't get nurses as it is. So there needs to be a lot of adjusting. That's why I asked Dr. Dueno and our chairman, Dr. McAvoy, we can't sit back on our laurels. We've got to get this blood service available to ambulances that can do it, so that we can move these critical patients without jeopardizing their ability to survive the trip. There's a bill out there now. It's moving forward. It's Senator Hinchey has this bill out. It's in committee yet. It's S6226. In essence, it gives ambulance agencies the authority to carry blood and blood products and administer blood. I really need your help with it. I'd love to see this body make a motion here today to support that bill, because it says a lot when the people that are doing all this work across the state support it and believe it's needed. We hope we can get it passed, but I don't know. We've got very few days left in session, so it might not get passed this year, but I believe in my heart it's going to get passed because it's sorely needed and what I've just been talking about. So I would at some point like to consider making a motion for us to support that. A couple other things. Mobile integrated healthcare. Sorely needed in this state. Other states take advantage of this opportunity to help people. It didn't make the budget this year, and we were really hoping that almost the last minute it would stay in, but it was cut. So the legislative committee is going to be looking at opportunities to maybe help move a new piece of legislation forward to make this happen. It's an uphill battle. Again, the nursing industry in the past has not looked forwardly at that like they have not community paramedicine, but we've got to get on the same page. We're all in this business together to save lives. And we're not trying to eat anybody else's lunch, because we don't have people to fill our own ambulances. Why would we want to try to get into the nursing business? So we need your help with that. Now that I've rambled a lot, I would like to make a motion that this body support S6226, allowing ambulances to carry blood and blood products.
Second motion.
Mr. Lewis, does that have a companion bill in the Assembly?
It does not. No, it does not yet, I don't believe, but
I believe there's an Assembly Bill A5789 put forth by Warner that's worded exactly the same.
Okay, so we
which is
can
in
get this
committee.
done. We can get this done. Why wouldn't we support this bill in hopes that we can get better care for our critical patients being transported by ambulance? We have a second, I believe. Okay.
Doug, you seconded it?
Yeah.
Yes, Dr. Isaacs gave a second.
Yes.
Any further discussion on the motion? If not, all in favor signify by raising your hand.
Aye.
Any opposed, same sign. Any abstentions? Well, that motion carries.
Thank you. End of my report. I appreciate all of your help and you listening to all of my concerns about the EMS system. It's a great system. It's a great system, but there's ways to improve. Thank you very much.
Thank you. Steve?
Mr. Chair, if I could make just a comment on the mobile integrated health that Al just mentioned. This is Stephen Kroll for the record. I think that it's important for us to recognize that what happened on mobile integrated health may have been somewhat self-inflicted by our industry. The traditional groups that had opposed this bill voraciously in the past sort of stepped back and did not put a lot of energy into the opposition of this in the budget. Maybe it's because they just had other things that were higher concerns. But we have learned that some of the reason it didn't appear is because some of the letters that were sent by our own field opposing Part S. So we had a really robust discussion at the last meeting of this body where we talked about Part S, and I know that there were people that were uncomfortable with how Part S was happening. They didn't like the fact that it was being done as part of the state budget, and they felt it deserved to be done through the regular legislative process. And there were other people that expressed, well, maybe that's the case, but the regular legislative process doesn't exist anymore for all intents and purposes. All major state decisions get made in the budget. For example, where did bail reform get fixed? In the budget. What has bail reform got to do with the budget? Nothing. Where did the decisions about natural gas appliances in homes get fixed or get done? In the budget. Where did the governor's plan for building new housing in communities not get done? In the budget. And she went into the press conference and said, it's not in the budget, it's dead. The budget is the vehicle. So what happened is people sent letters opposing everything in Part S from our field because that it was being done in the budget. I don't have the exact interpretation of any of those letters, but I believe that my colleagues that wrote those letters believed that they were opposing these things based on the process, but not based on the content. I don't think people on this body oppose mobile integrated health, even though I could be wrong. I think they felt this wasn't the way to do it. The problem was that the way those letters were interpreted by the receiving parties in the legislature and in the governor's office was, well, the EMS industry is split on Part S, so, we're not going to do mobile integrated health. So I think we kind of did a circular firing squad on this one. So I think, first of all, as Al said, we all need to work together to get mobile integrated health done. But secondly, we have to be very careful about how we word things because it is sad that we are being cited as the people that killed one of our priorities. And I don't think we did it intentionally. I think it was not, I hope it wasn't intentionally. So I thought that was important to bring up. We're going to have more attempts or more opportunities to do this. We have to separate policy from process. I think a lot of us agree that running a state with one bill every year isn't really the ultimate way. But look, that's the way to do it. So I appreciate you letting me make that comment.
Can I just make a counter comment? I think it's sort of unfair, to blame those parties, that had a problem, with Part S, as being the reason why mobile health, integrated health was sabotaged. And it wasn't sabotaged for the sake of sabotage. And it wasn't just about process, that was part of it. It was also about the proposal itself and some of the elements within it. So, yeah, I think some of what you're saying is a bit of a stretch here, and maybe something that we should take back, for conversation another time. I trust everybody in this body, comes to the table in the right spirit, So we just have to be a little bit careful, in how we characterize one group versus another, because I think that's really destructive to us as a body, something that really should be avoided.
Thank you. Let me move along our agenda here. Good time for safety.
Mr. Chair, can I ask a question about that last motion that was passed real quick?
Go ahead.
If I recall, that motion was only to support SB 6266 and technically not A 5789. So should we make a second motion and vote on supporting that second bill with the same language?
Good idea. Yes.
If that is the case, I make a motion that this body also supports Assembly Bill 5789.
Any further discussion?
Gandolfo, second.
If not, then all in favor of supporting Assembly Bill 5789, signify by raising your hand. Any opposed? Same sign. Any abstentions? That motion carries also. Okay, now, safety. Andrew.
Thank you, Chairman. We'll report back in September. We'll have a rough draft of policy 0013 revision. Mark Philippi is going to head that up and work on that. We will have an update on the management of escalation tactics. Mark and Brian Brunner are working on that together. Jennifer Salomon gave a report on what she's been doing across the state. I've asked her to give us a report for our meetings going forward. We'll start looking at Part 820.21 and Policy 0908, which is reporting incidents, to try to bring them in line through reg and also through policy. And then I'm asking all of our members here today to go back to their regions and start to discuss reduction of red lights and sirens. Member Kroll shared a study on that. So I'm asking you to go back to your regions, talk about it, and then if you have any reduction of lights and sirens in your region, if you can send that to me so I can review and we can try to put a policy statement together for the region. And then lastly, we will start working on performance standards that relate to safety. End of my report.
Thank you. Any questions for safety? All right. Moving along, quality metrics. Dave Violante.
Good afternoon, Dave Violante. At the last meeting, this body approved the new QI manual and guide. They're soon to come out. We're working through some of the formatting of the guide with Peter to get it out as soon as possible. We talked a lot about EPCR data flow issues. Ryan spoke a little bit about this. The data and informatics team and EPCR vendors have really been working to correct some of the data flow issues that could have some impact on agencies and hospitals. For example, some parts of the state are not getting upwards of thousands of records to the state or to hospitals. And so those groups are working through that process to ensure those records do flow well. There was a long discussion on this with representatives from both ESO and ImageTrend. Happy that both of those vendors were able to come and speak to this group and encourage them to continue to do that. And they are working with the DI team to meet all the validation issues. Some of those issues include, but aren't limited to NEMSIS and some of the state requirements. And so happy to have folks working on those things. Peter did provide an update on the biospatial progress for program agencies and agencies. That is just going to be a wonderful tool to use as a dashboard for some of the measures that we want to look at in doing quality improvement around the state, not only as a state, but for each individual agency and program agencies and regions as well. At the last meeting, and if you could put this up, Teresa, on the board, that would be great. At the last meeting, the Quality Metrics Committee presented a set of measures validated by the AHA, NEMSCO, FAIR, and Coverdell. And we, of course, don't want everyone to use all of these measures. There's 2 pages here, so if you can flip between the 2, that'd be great. And if everyone wants me to read them out loud, I'm happy to do that if you can't see them down there. But we want agencies to use maybe one or two measures to start with, right? And to look at these and how they work for their agency, their region, et cetera. And so we wanted to get these approved at last meeting, ran out of some time. And so to that end, the Quality Metrics Committee would like the SEMSCO to approve the currently presented list of quality measures. And to that end, I will make that motion.
Seconded by Mark Philippi. How many are there?
Approximately 21 here, I believe.
Okay. Any discussion on the motion? If not, all in favor signify by raising your hand. Any opposed? Any abstentions? Seeing none, carried.
Wonderful, thank you. Some of the next things we're focusing on is providing training through a variety of mechanisms, such as on Vital Signs Academy. We're going to be doing a 2-day NAMSP Quality Measures class at the Vital Signs Conference as a pre-con and workshop. And we are truly going to be actively helping program agencies, regions, and agencies to use these resources and help them make some significant progress. So that's some of our next steps with this. Part S affects us as well in the quality metrics group, and there's some direction on there on agency performance standards. So the committee is going to for sure collaborate with other committees to work on these topics, which can be clinical in nature, operational in nature, et cetera. So our group might be looking at things like how many meetings a year they're doing for quality improvement, the activity of the medical director in QI, having regular call audits, using the measures we've endorsed here to do today, et cetera. So these are some of the things we'll be working with the other committees on as we move forward as well. We do have two other asks. We'd like to do a funded pilot project for a quality improvement training program around the state, and want to gather a sense from this body in moving that forward, this program. So if we could have some sort of quick discussion about your thoughts on doing that.
Don't all speak at once.
I'll start, Mr. Chairman. Jason Haig. I think that's a phenomenal idea. A lot of agencies have QA programs in place, but like lots of other facets of any kind of business, you don't know what you don't know. So being trained on appropriately, being able to perform quality assurance, quality improvement would only benefit our providers, and at the end of the day, only improve the care to the patients across New York.
Thank you, Jason.
Mr. Chairman and Mr. Violante, would it be fair to, in the form of a motion, ask this body endorse a funded pilot project for dissemination of quality improvement training throughout the state of New York?
I'll second that if you need it.
Are you moving that, Mr.
I would so
Philby?
move, sir. Thank you.
All right. And it was seconded by
Mike
Masterson.
Masterson.
William Michael Masterson.
Thank you, David.
Valerie or Teresa, did you get that motion?
So the motion would be to support a funded pilot project for quality improvement training throughout New York State, as recommended by the Quality Metrics Committee. Want me to read the, I want you to type it, yeah. Okay.
All right. Any discussion on that motion? If not, all in favor signify by raising your hand. Any opposed, same sign. Any abstentions? Seeing none, motion carried.
The last ask that we have of SEMSCO is for this group here to ask their program agencies, regions, agencies, et cetera, to send people to formal QI education programs, whether it's this particular one or other ones that are out there. Those folks that could go include but wouldn't be limited to QI coordinators, medical directors, other administrative staff, et cetera, that would be involved in the QI process. And we just ask that folks really broaden this out to use the voices of more than just the QI committee itself, but all of our voices here for everybody. Thank you very much. I'll take any questions, and if there are none, then that is the end of my report.
Any questions for quality? If not, we'll move along to Jason and Terry on EMS innovations.
All right, thank you, Mr. Chair, and thank you, Terry, for jumping on board this crazy train of EMS innovations. We met yesterday afternoon. No seconded motions to bring to the table. However, we did have some discussion on some rather important items that are in our court again, secondary to things that were not approved in Part S. We did have an update on some ET3 programs. New York City reports slow but steady progress in their area, and the same struggles that they had last time, dealing with legal issues with alternative destinations, things like that. They did mention, though, that CMS has released a nationwide dashboard on ET3 that's able to give some insight on the program. And the biggest insight that they're getting out of it nationally is that the volume, the amplitude, if you will, of patients utilizing, well, not utilizing, they don't choose to utilize it, but patients that are affected by ET3 is lower than anyone would like. CMS may be coming out with a bonus payment for that as well. Steve Kroll is a phenomenal asset of information regarding telemedicine, and he did report out that there are about 30 agencies around the area that, around the state, I should say, that are doing a treat in place for telemedicine with physician guidance. And about 9 out of 10 of those patients that qualify to be utilizing telemedicine don't go to the hospital. That one remaining patient out of 10, that remaining 10% there goes to the hospital because the physician really thinks they should. There was a discussion on efficacy of some of these programs, and he also reported that NAEMT is looking at some legislation for federal payers to get on board with some of this telemedicine practice that's happening around the area. The committee, with the help of myself, Terry Hamilton, Jonathan Washko, and Steve Kroll, is going to put together a small tag, and we would welcome help from anybody in the webcast land or in the gallery. That's a recurrent ask all day, to help develop two documents of information. One of those being an educational infographic, if you will, for providers of the fact that it's okay to utilize alternative destinations in ET3 if they're enrolled in it, or they have a CP program or an MIH program. And then the other document would be an infographic document of information for the public that explains what ET3 and or MIH community paramedicine is. And that, this isn't mother jugs and speed and we just throw you in the back of the ambulance and take you to the hospital as fast as we can anymore. That's not what we do. With the elimination of mobile integrated health in Part S, we're forming a tag to start to identify what mobile integrated health is going to look like in New York State. If you have a mobile integrated health program, are interested in it, have a passion in it, please contact me, the chairman, or the bureau director to let us know that you're willing to serve on that tag. We definitely would appreciate the help. Before we get too deep into that, though, we are going to publish a short paper on the benefit of community paramedicine, mobile integrated healthcare, whatever it is going to be called, and the benefits of it. Myself, John Washko, Steve Kroll are minimally going to work on that, and hopefully we have some help as well. And we're going to ask the ET3 programs really 3 questions. What are you doing? What are your outcomes? And where do you think we're going? And that's some of the story and the data that we're going to put into this paper to educate folks on what this really is. Myself and Chris Singleton also had the opportunity in February, thanks to Marianne Pitoro and some others, and Mickey Fornes for getting us into the February meeting of the New York State Emergency Nurses Association. We spent about 45 minutes to an hour talking about what mobile integrated health and or community paramedicine is, what the mission of it is, and we have the full support of the New York State Emergency Nurses Association, and whatever they could do to help us move forward with mobile integrated healthcare or community paramedicine is at our disposal. So I look forward to a long and healthy partnership with them as we move this forward, and we do thank them for their support. Barring any questions, that is the end of my report, and thank you for your time.
Any questions for innovations? If not, Rob McCartan, do you have anything from program agencies?
Yes. Thank you, Mr. Chairman. At our program agency meeting on Monday, we did have some members from the DOH staff there. One of them being Amy, who asked the directors if anybody has any guidance documents or policies related to transport decisions around primary versus comprehensive stroke centers. So we will be helping her out. I do apologize, I forgot the reason why you needed it, but I'm sure she can share that if you'd like. The other thing is Mr. Weedman was also in attendance, and he spoke to us regarding the EMS training leadership program and trying to start rolling that out to providers within the state in the various different regions. We'll continue to work with him on that. The other thing is that he has been given the initiative, the goal, whatever you want to call it, that to the program agencies that we need to start looking at moving all the SEMSCOs onto the boardable in regards to their own platform for their own business. So each one of those directors will be going back, having those conversations with their SEMSCOs about that. The good thing is this whole finance thing has been talked about ad nauseum, but I will be working with the director and the finance team over at the DOH regarding why some of the program agencies are not expending all their money, so that we can maybe at least come up with a viable reason, or maybe work to help them spend all their money. The other good thing is the other flip is credentialing has been talked about as well. So I don't think I really need to cover that. And we did have a discussion regarding Part S and what has passed and how that will affect us as program agencies. Other than that, unless anybody has any questions, that is the end of my report.
Thank you. Any program agency questions? If not, EMS for Children. Amy?
Thank you. Some brief information about the EMS for Children grant. Our grant was up for renewal, and on April 1st, we were renewed for 4 more years, so very excited about that. They are asking very similar performance measures to the last 6 years. There's going to be a heavy focus on pediatric recognition and pediatric emergency care coordinators for both emergency departments and EMS, and heavier focus on disaster preparedness, whether that be natural disasters or reunification. There's a variety of topics of interest. In relation to that, there is a Pediatric Readiness Quality Collaborative through the EMSC EIIC, and they are enrolling through June. If you are interested in quality improvement but don't really know how to get started, they really do take the heavy lifting of it. So if you're a hospital or an EMS agency and you want to get involved, go on the EIIC website or email me, and I'll be happy to direct you. We also concluded the EMS for Children EMS survey, and that concluded on March 31st, and I hope as the EMSC data center works with that data and cleans it up, I will get some reports and be able to share that with you probably end of summer. So in September, I anticipate having some more information on that. We had our last EMS for Children Advisory Committee meeting last Tuesday, and our next ones will be September 5th and December 4th right here at the Hilton Garden Inn in person, starting at 1 p.m., lasting till 4 p.m. So you are all welcome to come join us. So at our meeting, we discussed a variety of topics. Safe transport of pediatric patients was one of them, kind of an update on what Martha Golke had started here at EMSC and how we have built on that. So much thanks to Martha for setting that up and setting us up for success. Also last week, I was at the Child Passenger Safety Technician Conference, which is held by the Governor's Office of Traffic Safety. And we had 2 sessions. So 2 of our EMS Pediatric Emergency Care Coordinators, Tom Orpikowski and Anthony Seng, gave a class with Peter DeAndrio, who is with the office. They gave a class on safe transport of all pediatric patients. And then in the afternoon, I gave a class on safe transport of newly born patients. So what do you do if the baby is born, and how do we get everybody and their mother to the hospital safely? So we also talked, right, thank God somebody giggled. We also talked about pediatric agitation. The work group is ongoing, so we'll have some more meetings and hopefully have some more on that next time we meet. However, Sarah Groover, who's one of our Family Action Network members on EMSCAC and also is a New York State paramedic and New York State educator, she has some classes on therapeutic communication, de-escalation, but a lot of heavy focus on pediatrics. So we'll be featuring her on Vital Signs Academy, and she'll also be at the Vital Signs Conference. We're very excited about that. Thank you, Val, for making sure that got in. Also, pediatric triage. I know that it's been a hot topic. It was included in the updated collaborative. STAC will be talking about it tomorrow. So we will continue to talk about it as well and work with STAC to issue some guidance. We also discussed length-based measuring tapes. And so much thanks to Megan Williams and her paramedic students for doing some of the heavy work of reviewing protocols and seeing what's what and asking some questions. She is going to give a report on their findings at our next meeting, and then we'll move forward and decide what recommendations we can make from there. We also discussed the Always Ready for Children ED recognition program with the Associated Emergency Department Pediatric Emergency Care Coordinator program that I hope will be rolling out this summer. I will be giving a presentation at STAC tomorrow, as this was a conjunction of EMS for Children and STAC, as the American College of Surgeons has a pediatric representative coordinator in their new grade book as a requirement to be trauma verified. Tune in tomorrow or stop by the Wolf Road Marriott and join us for STAC, and you get to hear more about that there. I have had a lot of ER staff, ER nursing, injury prevention folks reach out to me about this. Everybody seems very excited. And really, the goal is to make all emergency departments prepared for children. So even if, maybe they're not a specialized pediatric trauma center or a specialized pediatric hospital, that they will have the resources to care for children until they can be transferred, which is our goal and hope. And I believe that is all of the big stuff that we discussed.
All right, any questions for EMS for Children?
I have one, Dr. McAvoy.
Go ahead.
So Amy, in your child passenger safety session, when you were meeting with Governor's Traffic Safety Committee folks, and you had the obviously the CPS instructors there, was there any mention of use of funding, primarily from state GTSC funding, police traffic safety or traffic safety grant monies to buy safe transportation equipment?
There was not. I certainly could go back to Peter DeAndrio, and I believe it's Audrey Feldman, to ask if there's room for that or if all of that funding has been allotted. This was primarily an educational session to alert people to the new devices that have been developed over the last 3 years and have been released, so that previously, right, we gave the baby to mom and mom held onto the baby, and hopefully we drove real slow to the hospital and got everybody there safely. However, now that there's devices and we know better, we want to do better. So this was primarily informational, educational session on, hey, there are some resources out there now. Avail yourself of them.
I know that, speaking with Mr. Kroll, later last year, the federal government, through NHTSA, had released a considerable amount of funding specifically earmarked toward EMS that was funneled through Governor's Traffic Safety Committee. I don't know if too many EMS agencies have applied, and in my other hat as chair of our Traffic Safety Board in Monroe County, it was something that I'm trying to alert my regional agencies about, that there are funding available through the traffic safety grant programs. They usually have to have their applications in by May 1st. So application would start in January, February. But there is new information that there may be funding available for equipment if you can tie it in some way to injury prevention. So that's I think if we get agencies that are considering buying those specific types of equipment but have said, I just don't have the money for it, here might be a way.
Go ahead.
Apologies. I would just add on to that statement. I've also been part of some conversations at the national level around that post-crash care, and I think it's really important that we capitalize on that in New York State and think about partnerships with traffic safety. So I encourage this body and the members to look into opportunities for partnership. Just reiterating what you've just said.
Yes. So at SEMSCO, so National Association of State EMS Officials, the Highway Safety Committee, the HITS Committee, has been talking about that money being released, and NHTSA has really been pushing it. And I hope that they have some of that funding in the future released for these kind of devices, because they are critical to injury prevention in our ambulances. This year, I looked at some of that information, and it really was primarily dedicated to overall safety, not just a niche topic. However, I hope that they do that in the future. EMS for Children also released a substantial amount of money to the pediatric restraint crash testing development process. So previously they had developed the sled buck and some of the testing portions, but now they've released that extra money so that actual crash testing of devices, I don't know which ones, will be completed, and development of standards for those devices. So I know that there are 3 work groups going on currently, so that is finally in process and moving forward. So hopefully in the future we can make better educated decisions, because there will be some standards and crash testing behind it as well.
That's great to hear.
Thank you.
Any other questions for EMSC? If not, STAC is next on our agenda, but they have not met since our last meeting, and they are meeting tomorrow. So if we could just keep going with this meeting, you'll see them soon. Old business, any old business that people are interested in? New business? I have a couple of new business items in talking to Deputy Commissioner Morley. One of them comes from some conversations from our past chair, Mr. Philippi, and that involves recordings of minutes and records of stenographic records of SEMSCO. As you know, trying to find stenographic records is difficult, and they come off the website at a certain point. And so we would like to ask, or I would like to ask for a motion to ask the Bureau to create an archive of those so that people who are interested in the stenographic records of the meeting are able to access them historically through a website.
I'll make that motion.
I'll second.
All right. So any discussion on that?
Yeah, I want to support it. The discussion is the REMSCOs have found it useful, archiving past decisions and why, and discussions and why. So I think, the state not to, as a leader, follow suit, it only makes sense. So I do support it.
All right. Any other discussion?
Yeah, just very quickly, and Peter could probably, it's Gandolfo.
It's a matter of the public record, so they certainly should be available forever. The recorded minutes of a meeting.
think they're all documented. I think the issue is that the way that the website was put together was, as they put up one, they take down the other. And so I think what we need to do is just talk to PAG and say, hey, the way that you see everything on FIPIC, where it doesn't come down, set us up like that. That was the issue that was there. So yes, we absolutely can take that back. And actually, Val, if you can spearhead that one with PAG and have it about keeping the minutes up. Sure.
All right, all in favor of that motion? Any opposed? Any abstentions? So hearing none, that carries. Another item which is more complicated is to inquire about the possibility of actually generating minutes of the meeting, not stenographic notes of the meeting. And whether that would just be of the State Council and the SEMAC, or whether we would want that from each committee. Ideally, it would be good to have that for each committee, so that rather than having to read through 998 pages of stenographic notes, you could actually see a bulleted list of items from each one of the meetings. And I think that's a little bit more complicated, but I would like to ask for that, because I think that would help the members of this committee, especially when you're in absentia and you want to find out what happens and not necessarily read my sarcastic version of it. So that would be my motion, is to ask for minutes to be taken by the Bureau of each meeting. So a second by Al Lewis.
Yes.
Any discussion on that?
Yeah, Mike. As, again, with the REMSCOs, that's good, but I think the executive committee should review the minutes before publication. That's all I would ask. Because as you know, minutes from secretaries can vary from person to person.
As we see with the stenographic records. And, any other discussion on that? If not,
Just as a quick note to add on to what Mr. Masterton said, wouldn't those minutes then have to be approved before they can be posted?
yes.
Okay. That's all. Thank you.
All right, shut off mics. There we go. Al, can you shut off your mic? Thank you. So we did just take a look. It goes back to 21 right now, which is when we started putting it on the page, and those are all on there. Before 21, we'd have to go back and kind of recreate that a little bit, but that's something that we can take a look at. But it looks like it's started in the process. So.
Just a question on clarity of this motion. Are these going to be minutes for every single meeting, including committee meetings, or just SEMAC and SEMSCO?
Well, I think the intent it would be to try to get them for every meeting, or at least that's the ask, and then we can see what it ends up being.
I have a quick question. Who are we going to task with taking these minutes?
That was going to be my question.
I would ask the Bureau whether they're capable of doing that or not. It may require them to add some extra assistance, if that's the
And
case.
what about with, and what about like virtual in-between meetings? And are we looking at tags or just subcommittee in between meetings, or just subcommittee at SEMSCO?
I think I would start with SEMSCO, CMAC, and the subcommittees, and then we'll see where that goes from there.
So just for clarity, so to bring up Nice Vera for a second, who happens to put out minutes on a number of different meetings, are you referring to minutes more like that are highlights and bullets and kind of components of that, or something? Yes. So I would tell you the Bureau probably doesn't have the subject matter expertise to be able to take it in that detail, but we can look into options that might be available.
So the motion is to make that ask.
Yeah, and we've got a motion and second, right? So it's on, we're still on discussion.
Yes, sir.
I think that the important thing to note here is that we each committee chairs or anyone else who's here to report out at this meeting or at SEMAC or any other meeting for that matter, kind of repeat the same things over and over, and it would be really helpful if we had those notes in a consolidated and official form that people could then reference. So yes, it's great that Nice Fair does that. It's great that Dr. McAvoy does that on his own. I know Jason Haig does a version on his own. But I'd love to see the official version of that from what we report out on here to see these are the bullet points so that I can go through and say, okay, this was the Bureau report. As read into the record, here are the bullet points. So I don't have to read every line of what Ryan said, but I can see what you tried to give us information-wise.
Love the concept, don't know what it would be to implement. So I completely understand where you're coming from. I think it's a good thing we can look towards it, but that would probably be, contracted services that we'd have to put together in order to do it and do it right, I guess is, my answer on that one. And not only right, but consistently.
So all who are in favor of that motion, raise your hand. Any opposed? And any abstentions? So seeing none, that carries. The last item I want to bring up is the potential to add the alternates to boardable. And I don't know whether this really needs a motion or not. I think we may be able to just do it. So, okay, we will. Next, I have excluded the Diversity, Equity, and Inclusion Committee from reports inadvertently. So I don't know if, I think Dr. Rabers left and Jared is
Dr.
not
Rabich
here.
was so upset that you excluded him, he left before
He stormed out, yeah.
Yeah.
They did tell me, though, that they are finalizing a survey that they're going to send out, and I think it's on boardable, right?
Yeah, I think they've asked all the council members for any feedback on that one. They have a survey that's on boardable that they would like to send out. I do know that I believe they have a couple of new members of the task force, sorry, not task force, of the committee or tag that have joined since the last meeting. So those were two highlights that they have. If you have not seen it or you cannot access it, let us know and we'll make sure that it is put in the right place. I'm not sure where they put it. They gave me a message saying they put it on Portable. I don't know where they posted it, but I will find out and make sure that that's shared with everyone. And I believe it's actually, Jacob, correct me if I'm wrong, is it done in a Drupal? So we can actually share it by email and then wipe out the results so you can go through it just from a sample point of view.
Okay. Any other items of new business?
Yeah, I'll make them three quick. Number one, Happy Nurses Week to the brothers and sisters in our nursing and healthcare community this week. Number two, yes. Number two, we won't be here. Our law enforcement community is having Police Week next week, so thank you to all the law enforcement community out there. And the third one is just to end on a positive note. I'd like to see this group change. We went through F, we went through S, next it'll be X, Y, Z. We have to come to the realization that policies and laws get changed by budgets. So we have to switch our gears to have our legislative committee, our leadership. We all represent most of the community in the state. So if we all agree on point items and put those forward to the governor when they're making the budgets and the Bureau prior, there are things that we can agree on. I think we tear ourselves apart by saying, what we agreed with and what we didn't. And that's what happened with this budget. I'm upset. EMS is not an essential service. I'm upset I'm not licensed. You know what I'm saying? But there are other things that my REMSCO, other organizations wouldn't support. Had we parsed them out and said, these 15 things we agree with, you know what I'm saying? I think they all would have passed because, it's hard. I know I work for an administrative group, so the Bureau works for an administrative group, and they have to follow that process. That's a purview of the executive branch. But I think now we have to start reaching out as a REMSCO and SEMACs and SEMSCOs to put forward what we all agree upon. You know what I'm saying? Because I think if those were included in the budget, there would have been no argument across the board. It was an all or none, which happens to be politics today. I think we should, as a REMSCO, not tear ourselves apart. Some were for this, some were for that, but we all agreed on 14 items. We voted in that white paper. But I think the white paper came out as this body approved it, and it wasn't approved as a legislative document. That was approved as a vision of the future. I think had we put out a legislative agenda saying, these 14 items we agree with. So let's do that before the next budget, whatever that time frame is, because then I can assure you, all the REMSCOs, REMAX, the 14 members that represent regions, FASD, Onion, NTFARA, go across the list. Everybody supported 14 things. So I do have an ask, and I don't want to head that committee, Mr. Chairman, to have the Finance Committee, have the Legislative Committee start putting together, we all vote and approve these items and give them to the governor to act on. Thank you, sir.
Here.
There's a charge for you, Mr. Lewis.
And I think he said he was going to work on our committee to help us with it. Thank you very much.
All right. Any other items? You got something, Carl?
No, I was going to make a motion to close when you're ready.
Oh.
I'll second that.
Sorry.
That's what he turns on the mic
Valerie,
for?
Valerie
But
has
you cut me
something to
off
say.
before, so- Oh, hold on.
I forgot to include in Ryan's report that the State EMS Council Awards are due on July 1st. So please go back to your regions and remind them of that. And also, if you could put, not that this is a huge deal, but I get many applications in the email that are not sent to the regional councils first. So I forward them on to the regional councils, but just to remind everybody that whoever is nominating the individual, that needs to be sent to the regional councils, and the regional councils decide which nominees to send in to me. So, like I said, not a big deal. I forward them on to the appropriate regional council, but just a reminder out there for the regions to send all their nominations to the regional council. And also the Innovation Awards.
Innovation Awards,
Yep,
yeah.
I remembered.
Innovation Awards, this is important because by the time we have our next meeting, they would have been determined already. So there are 4 categories for Innovation Awards. They don't all have to be awarded, but we are trying to get to the point of, with the Innovation Committee and the work that everybody's doing around the table, to highlight the really good things that are happening around the state. So if you have an agency or something that is doing something innovative, please, please, please consider submitting those. I believe that's on the EMS Forms page for the Innovation Awards to be submitted. They come directly to the Bureau. So please give that one some thought if you have some agencies doing some great things. The topics are all on there, and feel free to make some nominations. You don't have to just make one. If you have 3 or 4 that you want to nominate, you can nominate them all, and then, the selection will be made, from there.
All right. Now, Carl.
Gandolfo, motion to close.
Second.
Second.
Happy
Thank you
EMS
all.
Week, everyone.
See you in September.